We have many speakers who are from far off places, and they are unwilling to travel by air right now. So we have tried to link them through the internet, and many eminent personalities are there in the program. So I hope everybody who is doing trauma, who is doing scopy, who is doing plasty, we all will be benefited. We have inaugural function at 1 o'clock around, and we have many speakers who are from far off places, and they are unwilling to travel by air right now. So we have tried to link them through the internet, and many eminent personalities are there in the program. So I hope everybody who is doing trauma, who is doing. So this was the digital India, nothing else. Whatever you speak, mind it, it is getting recorded. So we have Dr. Sanjay Dhawan, our president, UPOA, and we will be having the inaugural function around 1 o'clock. Dr. Ravi Kant is here. So, and the EC meeting, for the just information, we are having around 1:30. So let's begin with the program, and let's enjoy. There is an evening banquet. I request those people who are planning to return by the evening, we will start very early. So please stay for some time, have something, and then move away. Thank you.
Thank you everyone for coming. So we have our first session on arthroscopy. So I request Dr. Aishri Goyal sir, Dr. Sanjeev Avasthi sir, and Dr. Ashutosh sir to please be the chair for this session.
Sir.
So I now request upon Dr. Neeraj Srivastava to please come up on the dais and start off with the first series, which is basic shoulder arthroscopy.
Thank you, everyone. So I'd be speaking about basics of shoulder arthroscopy. Since all of us first start with knee arthroscopy and then we evolve to shoulder arthroscopy. So I'll have to tell that what is the difference, how we have to evolve from knee arthroscopy to shoulder arthroscopy. So first is the indication. As you all know, we can broadly classify the indications into two parts. First one is instability and second one is pain. For instability, we have indications such as Bankart repair. Addition to that, we can do remplissage, and even now people have started arthro-Latourette surgeries also with the help of complete arthroscopy. In pain, we can do it diagnostic, some loose body removal, rotator cuff debridement or repair, slap repairs, subacromial decompressions, AC joint pathologies, release of scar, contractures, frozen shoulders, synovectomy, and biceps stenosis or tenotomy. So technique, as I said, we all evolved from knee arthroscopy to shoulder arthroscopy. There are two major differences which we face when we come to the shoulder arthroscopy. First one is, like in knee, we have the tourniquet with us. So bleeding is never a problem in a knee arthroscopy. But in shoulder arthroscopy, if you start with the basic problem which everybody faces is the bleeding, because they don't have any tourniquet with us. So one most important thing which I always feel is the anesthetist, which is very important for starting a shoulder arthroscopy. You have to have a hypotensive anesthetist, and it has to be under general anesthesia. General anesthesia usually is not good for shoulder arthroscopy because there'll be pain and there'll be bleeding, and you cannot control bleeding once it started, and you'll be literally blind on the table. Second, the shoulder joint is not as superficial as the knee joint. So the portal placement is also very important. You cannot blindly go into the shoulder. So you have to first do markings. And also once you start the shoulder arthroscopy, the shoulder joint swells up. So the normal anatomical landmark also goes off. So marking is very important once you start your shoulder arthroscopy. So first one is the bleeding control, hypotensive anesthesia. And second one is the marking, which is a major difference between shoulder and knee arthroscopy. Third one, again, the pressure control. While doing the shoulder arthroscopy, you have to have pressure control. So using a pump makes your life always easier. Also, you have to use underwater cautery in shoulder arthroscopy, especially in working in the subacromial space. So these are few differences which you have to keep in the armamentarium once you are switching from knee arthroscopy to shoulder arthroscopy. So now coming to positions. Two positions which we are using commonly in shoulder arthroscopy. First one is the beach chair. Second one is the lateral decubitus. Beach chair is more of an anatomical position in which you keep the patient upright, and the orientation of the glenoid in the joint is same as the normal patient. In lateral decubitus, you make the patient to lateral position and give traction, and by that way you position the patient. Now, what are the advantages and disadvantages? So lateral decubitus, it is easy because you don't need any special equipments. There are arm positioners for lateral decubitus also, but most of us are just using the pulley and the traction equipment, and we are keeping the patient in lateral position. So it is easier, and the traction is actually accelerates the labral tears, and the cautery bubbles, whatever you are creating while the surgery comes sidewise. So the vision is not hampered. The cerebral perfusion, which is at risk in the upright position, is not there in the lateral position. So your anesthetist will be very happy if you are doing the arthroscopy in lateral position, while in beach chair position, they are scared of the hypoperfusion of the brain. The disadvantages are, it is a non-anatomic orientation. The glenoid is parallel to the floor, and you have to reach around for the anterior portal. And if you have to convert the surgery into open surgery, then lateral decubitus position is not a good position because you have to reposition the patient, repaint and drape it. And it is not ideal for patients who cannot tolerate regional anesthesia. And excessive traction, especially the lateral traction which we are giving, can cause neurovascular soft tissue injuries. But in our surgeries, we are not usually giving lateral traction. Mainly the straight traction is used. Now the beach chair position advantages are, it is upright anatomic position. There is ease of examination. Once the patient is under anesthesia, you can examine the patient, then you can start your arthroscopy. But that ease is not in the lateral decubitus position. But again, the positioner is expensive as not readily available. Plus the anesthetist is not very comfortable. So most of us are actually doing in beach chair position. In general, if you ask me a rule of thumb, for instability surgeries, the better position is lateral position. It is very easy to do instability surgeries in lateral position. But once you are doing cuff surgeries, the beach chair position is more easier. Now we come to the markings. So once the patient is anesthetized, you have to do the marking. This is the clavicle, this is acromion. So this is the coracoid. Now the most common portals which we are using is the posterior, anterior and the lateral portals. After that, we can use the accessory portals also. The posterior portal is our main viewing portal, which we make after marking. So this is the posterior tip of the acromion, almost 2 centimeters roughly down, and 1 centimeter middle is the posterior portal. Once the arm is in traction, you will feel the soft spot. You have to mark it. You have to put your scope, and you will get a giving way sensation. Remember, it is not that easy to enter a shoulder joint as it is in the knee joint. Even after experience, many surgeons struggle to enter the joint in obese patients. So posterior portal is the weaving portal. Other portals, one more important thing I'll tell you, please mark the coracoid and try not to go medial to the coracoid, because this is not the safe zone. This is the zone where you can get injuries, and these structures are beyond orthopedicians management. So you have to stay lateral to the coracoid. So from lateral to the coracoid till here, you can make as many portals as you can. But the major portals are the anterior portals, which is slightly lateral to the coracoid, just below the acromioclavicular joint. The lateral portal, which we use for cuff surgeries and subacromial space, it is approximately 1 to 2 centimeter lateral to the acromion. With that, you can make accessory portals also, anterolateral portals, anterior medial portal. You have Nevasia portals for slap repairs. These all you can make as you require, but try to stay in the safe zone, lateral to the coracoid. So I'll show you how to make the accessory portals. Once you make the weaving portal, posterior portal, all the other portals has to be made through your vision. You have to place a spinal needle and then you have to make a portal. Like I'm showing a video in which I'm making anterior portal. Excuse me, there's some technical issues. So actually, laptop change kiya, that is causing the problem. So I'm inside the joint to the posterior portal, and this is my needle. So once I'll make sure that in this I have to do a Bankart repair. So once I'll make sure that my needle is reaching the area which I have to work. So once I'm sure that this will be a proper position for my portal, anterior portal, then I'll take it off and take a knife. I'll just fast forward it. Then put my Bissinger rod and put a cannula over it. One more important thing is, if you're not putting cannula after making portal, you might lose this because the shoulder joint swells up once you're doing the surgeries. So all the portal, either use a cannula, and even for posterior portal, once you are removing your scope and putting in the anterior portal, you have to keep either the cannula or a Bissinger rod so that you will not miss the portal. So in this anterior portal, I am using a cannula. So this will be my working portal. So this is how we insert a cannula, and this becomes our working portal. Another video I'll show in which I'm showing how to switch the portals. So this is the underwater cautery, and I'll switch from the posterior portal to the anterior portal. So I'm coming out from the posterior portal and going back to the anterior portal to view my posterior glenoid diaphragm. And I'll just show how I'm keeping my Bissinger rod inside. So this is my Bissinger rod in the posterior portal. So by this, I will not lose my portal. And once I'm coming back to the posterior portal, I can just put my scope through this Bissinger rod. If you have missed it, then it is very difficult to go back again to the same portal. Now I'll show a small diagnostic round, the normal structures, how they look. So this is a normal diagnostic round. This is the biceps, which is called the lighthouse of the shoulder. So once you enter the joint, if you see the biceps, that means you are inside the shoulder joint. So I will start my diagnostic with this. You have to see the whole length of the biceps tendon, the long head biceps. After this, this is the subscap tendon. And the space between subscap and bicep, this triangular space is rotator interval. Okay. You have to see the subscap tendon for the whole length. Also, you have to pull the biceps initially to check whether it is tight or not. This is your MGHL. In this video, all these structures are normal. You'll palpate through your probe. This is MGHL. Now you'll come to the glenoid. This is the glenoid cartilage and the labrum. This is your anterior labrum, which is the place for pancreas tears, anterior inferior tears, which is probably the most common thing in which we are doing shoulder arthroscopies. Now we'll go all the down to see for the any labral tears. In chronic labral tears, you can see abscessal lesion also in this place, which is not very much clear in the posterior portal, but from anterior portal you can see. But this is the place where you have chronic labral tears, and labrum is lying way down. This is the humeral head. The cartilage is fine. And below is the glenoid, bray area. In cases of bone loss, you have to quantify the bone loss of the glenoid over this area. Now we'll go more inferiorly. The labrum is intact here also. This is the place where IGHL is there. And this will be the, on your left will be the bare area where we'll find Hill-Sachs lesions. This area is for Hill-Sachs lesion. Now again we'll come back and we'll see the biceps tendon, and this, the superior area is the cuff, the supraspinatus. So we'll palpate for the any cuff injuries. Here the cuff is also looking fine. It is completely looking fine. So with this, we complete our diagnostic shoulder arthroscopy round. Thank you.
After a brief and a very good introduction to basic shoulder arthroscopy by Dr. Neeraj, I request Dr. Sanjay Srivastava sir to please come up and share some light on shoulder impingement and the technique of subequivalent decubitation. Next slide.
जी सर.
Good morning, friends. First of all, I would like to congratulate the organizing team for organizing such a wonderful physical meeting after a very long time. We all were looking forward to meet each other. And after such a wonderful introduction to shoulder arthroscopy by Dr. Neeraj, few things I would like to add that it is commonly understood that keeping a traction apparatus and arm positioners are 100% mandatory for the shoulder arthroscopy, but I don't think that is the case. It makes your life easy and it improves your functionality, but you can do it without that, because when I started doing it, I don't have anything like that. And we used to do it with good level of comfort just by using apparatus available in our theater only. This is not the time to discuss that. I'll discuss that at some other meeting. My presentation would be focused on impingement syndrome, and the treatment of impingement syndrome. I understand that this is one diagnosis which is actually very much underdiagnosed. There are a lot of people who are suffering from impingement syndrome, and we don't look at it and we don't treat it. We just label it as a periarthritis. That's the commonest diagnosis we make when a patient comes with a shoulder pain or any shoulder disability to us. other than instability, all are labeled as periarthritis. Actually, we don't go deeper into it to look in the cause and how to treat it. When you talk about impingement per se, what is impingement? Impingement means this is the subacromial area. So any tissue which is leading to crowding of this place or narrowing of this place, causing compression over the tendon and soft tissues and leading to inflammation, that becomes the impingement. The causes can be variety. Actually, it is impingement of the subacromial bursa or rotator cuff muscle or biceps tendon. They all run in the same area. And if there's any pressure on these structures between the acromion or CA ligament or the AC joint or coracoid posterior humeral, all this incorporates the impingement. It's a very large area with multitudes of structures into it, and which leads to problem. Rarely this rotator cuff tenodesis is what the diagnosis which we often see on MRI. That also leads to impingement because the rotator cuff itself is inflamed, thickened, and again leading to crowding of this space. Commonest cause for impingement syndrome is the type 3 acromion. That's the most important cause, and which is to be identified correctly and treated correctly. That's very, very important because that can lead to further complications and ultimately the degenerative rupture of the rotator cuff and degenerative of the joint itself. Other less important causes are the degenerative changes in the acromioclavicular joint leading to osteophyte formation under the joint, and that again causes the crowding of this space. Rarely the thickened coracoacromial ligament, it is in the anterior part of the subacromial area, and that can cause impingement. Anterior acromial spur is a rare diagnosis, but it is a very, very important cause because it, as soon as it is identified, it has to be treated surgically. You cannot treat it medically. Rarely, again, the overdevelopment of supraspinatus in heavy bodybuilders and weightlifters, that can also cause crowding of this space secondarily to the overgrown muscle. And one of the rarest causes is a low-lying acromion. The space itself is narrow in the patient, and any minor disturbance will lead to impingement. The commonest cause of the impingement that we have talked is the subacromial, the type 3 acromion. Type 3 acromion, this is type 1, this is the rarest type of acromion what we see. This is only in the 9% of the people it is there. Majority of us fall in this type 2 acromion, which is called the curved acromion. The anterior part of the acromion is curved down, but it is not causing any symptom, not causing any trouble to the patient. But the type 3 is the most dangerous type because the anterior end of the acromion is hooked down, and that is called hooked acromion. This is which is giving trouble because this hook was causing pressure over the rotator cuff and the structures underneath, and that can lead to rupture and symptoms, and later on the rupture of the self. When we try to classify, the NEE had given a very clear-cut guideline to classify these injuries. A very simple classification just related to the progression of the disease. The type 1 or stage 1 is when there is only an edema and hemorrhage. Patient is having symptoms related to that we'll discuss later. Type 2 when there's fibrosis and tendinitis has set in, and type 3 when or stage 3 once there's actual bone spur formation and tendon rupture and leading to further degeneration of the joint. A Copeland and Levy classification is a more detailed classification which again classifies the severity of the disease on both the sides, acromion side as well as the bursal side. I think it is more useful in a research setting where you really want to quantify the disease and you want to note it down for further comparison. In stage 1, the patient will come to us with dull ache and activity related or stress related pain. You can see some tenderness in the bicipital groove and as well as the over the greater tuberosity area. The pain is usually in the painful arc. We all know what is painful arc. Painful arc syndrome can be because of the impingement. It is not only because of impingement, but it can be because of impingement. And the positive impingement sign is the most important thing which we examine and see in the patient. to reach to the diagnosis. So painful arc on examination. Hawkins test is the key for diagnosis of impingement syndrome. It has got highest sensitivity and specificity as far as impingement syndrome is concerned. Although knee sign is also commonly used in OPD practice, and we all do it to reach to a specific diagnosis. One diagnostic tool which helps even in OPD to reach to a final conclusion is to infiltrate the subacromial area with a 2% xylocaine 10 ml solution, and we wait for 5 to 10 minutes, let this local anesthetic act, and if our symptoms disappear or patient becomes pain-free, that is a diagnosis that subacromial area is impinging, there's inflammation, and that needs to be addressed. This can be used as a diagnostic measure also, we all do it. Just infiltrate xylocaine along with the depot steroid preparation, so that if there is some inflammation, that can be controlled, and most of the patient, they become pain-free with this single injection only. This is how your knee sign is done. You pronate the arm fully, and then in pronated position, you try to abduct it beyond 90 degrees so that the greater tuberosity is impinging under the acromion arch, and that is causing pain over the anterior part of the shoulder. So if patient is complaining pain in that area, that means impingement is taking place and a test is positive. Other sign which is what we talked about, a more sensitive or more specific sign is the Hawkins sign. The difference is the arm is kept in 90 degree of forward flexion, and then you try to do forced internal rotation of the shoulder. Again, the purpose is to impinge the greater tuberosity under the subacromial arch, and that will lead to pain, and a test is positive. So if Hawkins and Neese tests are positive, most likely we are dealing with the impingement syndrome, and we can again confirm it with a Neese infiltration test. As far as treatment is concerned, in stage 1, treatment is simple, what we all do in the OPD practice. NSAIDs, rest, the movement which is causing pain or discomfort has to be avoided. Some physical therapy can help. If patient is having constant discomfort, night pains, on examination, we find crepitus on movement of the shoulder. If there's a catching sensation or there's range of motion is decreasing, that means impingement syndrome is progressing and we are leading toward the second stage of the disease, and we have to act to treat it differently. This is how we inject the area. It is, most of us inject from the anterior part of the shoulder because we are used to injecting the bicipital groove. But here it is very, very important to inject in the subacromial area, because if you don't inject properly there, you will not get the result. So this is how a subacromial injection is given, and if it is positive, that means it is a grade 2 subacromial impingement syndrome, and we have to investigate it further to reach to a final diagnosis. Apart from basic shoulder x-rays, the certain x-rays which are important as far as impingement is concerned, one is your notch view or Y view or scapular view, what we call. It beautifully shows the subacromial area, and you can see a large osteophyte coming down towards the subacromial area, and this will be causing impingement over the structures underneath it. So this needs to be addressed surgically. Another view which is important is a Zanka view. Yeah. That is 20 degree caudal view of the AP of the shoulder, so that your beams are running parallel to the subacromial arch, and any growth below the subacromial arch will be visible very clearly in this area. You can see a large bone formation or calcification under the subacromial. Again, it is causing a bony encroachment, and that needs to be addressed surgically. Of course, MRI, we all do it now, but MRI is important as far as soft tissue structures are concerned. Bony structures, we have to rely more on the clinical examination as well as X-rays only. But MRI is must before going beyond the stage 2 treatment to ascertain what kind of soft tissue damage is there, what is the condition of the subacromial area, how much encroachment is there, what is the condition of tendon, so that we can explain the prognosis and plan our treatment accordingly. In stage 2, again, the rest, non-steroidal anti-inflammatory, subacromial injection, physical therapy, range of motion exercises as patient tolerates, of course, pain control. And once pain is less, patient is comfortable, strengthening exercises. If patient is not responding, then comes the role of surgery, that is acromioplasty can help in these cases, and it gives wonderful result, whether you do it open way or you do it arthroscopic. The advantage of arthroscopic is that you have a full diagnosis of the disease. Even the intra-articular and other structures can be assessed very well. But if you are very sure about everything, you just want to do an open arthroscopic procedure, open arthroplasty or acromioplasty, that will give equally good result as far as outcome is concerned. This is what you do. There's a hooked acromion on the anterior side. You have to remove this and you have to make your acromion coplanar so that there is large space for the movement of the structures under the and sometimes you really have to remove this CA ligament also because it is thick and inflamed, and it is also a cause of impingement. So if you don't remove it, you just remove the bone. Sometimes the soft tissue impingement also is causing pain and discomfort. So we have to remove it. So right from acromion arch to the coracoid process, you have to create a clear space. And it is important to understand that anterior 2 centimeter of the acromion is the only cause of impingement. So we need not to work on the posterior aspect. It's useless. You don't gain anything there. And once you do an arthroscopy, you see that this area is actually good enough for all the movement. You have an impingement in the anterior part. Sorry. This is how the impingement surgery is done. Once we are abducting our shoulder, this anterior part of the acromion is actually impinging and causing pain. So you have to correct this anterior spike which is there, and it has to be removed, and the whole area has to be made coplanar. So this is how it is done. You remove the bone, excess bone which is causing impingement, and then try to make the area flat and more space for the tissues to move, and so that there is no impingement when patient is doing movement. As Dr. Neeraj has very nicely showed the portals, I must say that there are 3 portals which are primarily used as far as impingement surgery or subacromial decompression or acromioplasty is concerned. That is the anterior, standard posterior, and lateral. Sometimes you have to supplement with the anterolateral and the posterolateral portal depending on the type of impingement you are dealing and type of procedure you're going to perform. It can be done under GA, scalene, block, whatever you are comfortable, your anesthetist is comfortable. I usually prefer to do subacromial decompression in beach chair position. I'm more comfortable working under the subacromial area. And it's very easy. You don't need any traction device, nothing. You can just use a simple skin traction kit, apply over the forearm, and tag it over the simple drip stand anterior to the patient. And that is maintaining your arm like this. And then you can just mobilize your elbow and change your position. That is the advantage of beach chair position. You can keep your elbow at any position. You can give traction. You can rotate. That is very important when you are working on the rotator cuff. So that is why most of us prefer to do it under beach chair position. Portals we have discussed. Sorry. A quick arthroscopic procedure. A diagnostic arthroscopy, as I said, intra-articular structures can be identified. This was a case of rotator cuff in which I had to do it. So I've just skipped that portion. This is the CA ligament, which is frayed and inflamed. Most of these areas, they are inflamed and a lot of bleeding taking place. So you have to keep a pressure high. You have to keep the blood pressure of the patient low. And you quickly remove all inflamed tissue. That's the best way to stop bleeding, to get rid of the bleeding. And using this radiofrequency probe to stop bleeding and to clear the subacromial area with the soft tissue. This is the acromial joint, this is acromioclavicular joint, the volar capsule. I'm just trying to reach to the middle side so that I can clearly identify what all is there. And this is the lateral side. You can see this, there's a large osteophyte formation, and there's good enough bone formed here like this. And this all needs to be tackled and removed. So you can just take a burr, a 6.5 or 7 millimeter burr, try to make a gutter here so that you have make a gutter of almost 5 or 6 millimeter, and then you remove everything anterior to this gutter, keeping your plane in the same plane as the depth of the gutter, so that you know you have removed approximately 5 to 6 millimeter of the bone from there. So that's a very easy way of doing it in a quantified way, so that you don't remove excess of the acromion and risking the fracture in the future. You can see another case is there. There is a large osteophyte on the anterior side, which we have seen on the X-ray itself. So you have to remove this. The whole of the anterior osteophyte has to go. It is of no use. It is not working. It is not having any attachment. So you have to remove it totally. Then in this specific case, actually there was a acromioclavicular joint degeneration also. So I have to remove that. And once lateral anterior clavicle is removed, then we try to just flatten the whole of the acromion to create a total flat surface under which this is your AC joint. I'm sorry, this is the acromioclavicular joint, and we have to remove this, the lateral anterior clavicle and the acromion, because it's a degenerative joint, is causing pain, so it might cause pain later. So I just took a chance to remove it, and then just flattening the whole area using a radio frequency probe to stop bleeding. And you can see down there, there is a ruptured cuff, a large cuff, which needs to be repaired, which was repaired later. Normally, in most of the time, we used to do decompression, and then we used to do rotator cuff repair to increase the exposure. But now I think most of us agreed that first we do the repair and then we go for the subacromial decompression, because repair takes longer time and there's a lot of extravasation of the fluid around. And once you do a subacromial decompression first and do rotator cuff later, then the space is crowded and working becomes difficult. So first we do rotator cuff repair and then we go for the subacromial decompression if you find any structure that needs to be decompressed. Rehabilitation is very simple. You have not done any damage. So you can just give a sling, start pendulum exercises, range of motion exercises as patient tolerates, and you keep increasing progressively. But after 3 weeks, when patient is pain-free, he has regained good range of motion, you can go for strengthening exercises. So in impingement syndrome, what is most important is to diagnose it early, because it will lead to further degeneration and rupture of the rotator cuff. That is very common what we see in practice. And initially treatment is conservative, grade 2, conservative plus local injection, and grade 2 advanced, which is not responding to conservative treatment, or grade 3 that you have to go for the surgical treatment. Thank you very much for your patience hearing.
Thank you, sir, for the elaborate talk. The third speaker is Dr. Arun Gupta. He will speak on shoulder instability, quantifying glenoid and humeral bone loss. I think it is online. Dr. Arun Gupta.
Yeah. Can you hear me? Hello?
Yeah.
Can you hear me? Hello?
Yes, sir, we can hear you.
Okay, can you see the slide?
Yes, Arun, we can see your slide.
Okay.
Rajkumar here. Good morning. Yeah.
Good morning, Dr. Rajkumar. Meanwhile, I share the screen. Let me thank at the outset UP Orthopedic Association, especially Dr. Ashish and Dr. Uttam Garg in particular. And here I bring a greeting from the city of Agra. As we all know, that arthroscopic Bankart repair is considered as standard care in recurrent shoulder instability. However, if we look at the longer results, there are failures up to about 10 to 15%. And if failures are there, we need to know about the causes of failures. What are the causes of failure? That whether we have done the right procedure or we have chosen the correct indication in a correct patient. So in that sense, this is a landmark paper by Stephen Burkhardt and Joe De Beer, in 2000, this is a study of about 200 cases, and they have come to the conclusion that the failure rate was higher in cases with significant glenoid and humeral bone loss. They have further divided that what is significant bone loss. On the glenoid side, on arthroscopic appearance, the normal pear-shaped glenoid turns into an inverted pear-shaped glenoid. And on the humeral side, in athletic function position, that is 90-degree abduction and 90 degrees external rotation, the Hill-Sachs or the humeral defect starts engaging. So what is the problem? So when the glenoid is anteriorly deficient, there is less shear resistant and less safer arc for the humeral head, and it easily subluxates or dislocates. Remember, there are various types of glenoid bone loss. In acute setting, that is up to 3 to 4 weeks, this bony Bankart depicted in the most left picture is an acute fracture and can be repaired as a normal Bankart repair. After 3 to 4 weeks, it partly gets treated, and still in a non-demanding patient, you can repair and get away with it. But remember, in a recurrent dislocator of multiple times, there could be a complete attrition of glenoid, and a normal soft tissue repair will not suffice. But the question arises that regarding glenoid bone loss, how much is too much? The stalwarts like Easy and Itoe have come up with the concept of critical bone loss up to 21% of glenoid length that may cause instability and limit the range of motion of shoulder even after a good Bankart repair. What is the clinical relevance? That the results of this study suggest that the measures to restore the arc of glenoid concavity may be beneficial in terms of both stability and motion for patients who have glenoid defect with the width that is at least 20% of the glenoid length. Now, in 2015, Tokish et al. Have brought this critical loss point to even 13.5% on MRI and 3D CT scan based research work. But remember, this study has been performed in high demanding athletes from their Army Medical Center in Honolulu. So remember, this subset of subjects were different from normal individuals. How do we quantify it in a clinic? Remember, as we all know, that our eye can see what the mind knows. So when a patient comes to in your office, if he gives the history of multiple dislocation, we should suspect for a bone loss. And if he gives the history of dislocation even while he's sleeping, when the dynamic restraints are knocked off, that means there is some amount of bone loss which can lead to dislocation even in sleep. Then mid-range instability, that is in about 45 degrees of abduction and external rotation, the shoulder is dislocating or the apprehension sign is positive, that is again a warning sign. Then revision and failed procedures like a failed Bankart or in revision surgery is a no-brainer. We have to look for the bony defect. And while examining patient clinically, you find an audible or a palpable clunk as again an indicator of significant bone loss. So when the patient comes to in OPD, we order a shoulder AP and lateral view. So the AP view conventional AP view doesn't gives the true morphology of the anterior glenoid, and it doesn't shows the joint space. Whether what we require is a Gracie view, which is AP of the scapula that is around 30 to 45 degrees from the plane and is taken in 30-45 degrees of plane in order to negotiate the joint space. So in this true AP view, which is in around 45 degrees lateral, you can see that the whole glenohumeral joint space is visualized, and you can see the anterior inferior glenoid, and it is easy for easy evaluation. Whereas in conventional AP view, there is always an overlap of glenoid and humerus, and you cannot evaluate the glenoid in this particular normal conventional AP view. So in this true AP view, if you see that, you can see a dense cortical line, which is because of superimposing anterior and posterior cortex, means the glenoid is okay. Whereas on the left, if you see that this dense cortical line is incomplete inferiorly, that means there is some bone defect anterior inferiorly in this particular glenoid. Another view has been described by Gilles Walsh, is a Bernaccio view, which is not really done right now, but is not done now. But in places where CT is not available and there are severe financial constraints, we can still do it, which essentially gives the X-ray beam in about 30 degrees cephalad to caudad, and the patient puts his hand on his occiput, which essentially shows us on the top is the humeral head and the glenoid in toto. And what we have to look is that anterior, this is anterior, this is posterior, that this triangular of dense sclerotic bone is the anterior rim of the glenoid. Coming to the example, this is the picture of the normal shoulder of that particular patient. And you can see that the dense sclerotic triangle anteriorly, whereas there is a small bony chip, which is a bony Bankart, and the anterior part of the glenoid is deficient. Another example, here you can see
shops in open either 10:30.
The cliff. You can see here that there is a deficiency of the anterior bony rim, and there is a cliff sign in which the head can easily subluxate or dislocate anteriorly in this particular patient. The easy view, which is called modified Bernaccio view, has been described by Sugaya, which he calls as a TV watching view, and it is easily, the X-ray can be easily performed with the same picture which is given in the Bernaccio view. This is just for the ease of shooting the X-ray. The principles of quantification in the workhorse is 3D CT scan, and in which we can work in two fashions. That is the linear fashion, where we outline the normal glenoid rim and diameter of the inferior glenoid is taken, and then we subtract the amount of the bone loss in that. And the another method is the surface area method, in which the intact glenoid surface area is calculated, and then the defect area is subtracted from that. So you graduate your radiologist to fetch you a 3D CT in which the inferior aspect can be modeled on a circle as proposed by Sugaya et al. And the defect on the anterior inferior aspect can be quantified by various formulas given by various researchers. So one such formula has been given by Sugaya from Japan, in which you can calculate the area of bone loss by this formula, that is B, which is the surface area of the osseous fragment divided by the surface area of true fit circle multiplied by 100. So this is one method. Another method, which is arthroscopic, given by Burkhardt, and he has given his formula to calculate the bone loss. But one should remember that this is an arthroscopic procedure, and bare spot has got intra-observer bias depending upon the placement of posterior viewing portal. So what we do in our routine practice is that we compare the dimensions of opposite shoulder, which is the normal one, as proposed by the Moon group in this CORR paper in 2013. And then we calculate the maximum AP dimension of normal shoulder, maximum AP dimension of affected shoulder, and we use this formula of glenoid bone loss A minus B upon A into 100 to calculate the bone loss. Various techniques have been described and summarized here in this nice paper of recurrent shoulder instability, that is current concept of evaluation and management of glenoid bone loss. And one can go through this paper and choose the best method in their clinical scenario. Let's come to a couple of cases. In this case number one, the 26-year-old male right-hand dominant, desk job, a recreational weekend warrior, road traffic accident about a week back, complaining of dislocation of right shoulder, which spontaneously reduced at the time of accident itself, presents with pain and restriction of shoulder range of movements, walks in with this normal shoulder AP view, which doesn't gives us any information except that shoulder looks reduced back to its place. When ordered on CT scan, you can very well see on 2D CT scan that there is a Bankart lesion anteriorly with a huge chunk of osteochondral fragment anteriorly. And on 3D reconstruction view, you can see there is a big bony Bankart anteriorly. And then arthroscopy has been done. And the arthroscopy, the hematoma is cleared. And you can see this is anteriorly, this is the bony Bankart, and which is repaired well. And after 6 months, you can see on the repeat CT scan, it is very well incorporated and patient is fully functional. Another case, a 22-year-old male, right hand dominant, history of post-traumatic recurrent dislocation. And the last dislocation was more painful and has got about more than 25 episodes of recurrent dislocation. And remember, a warning sign, he has got a clinically mid-range instability signs positive. On X-ray, again, the normal AP is there, which doesn't gives us any clue, but it gives some clue that here the coracoid is, there is some breach, which has confirmed, which is confirmed by a 3D CT scan that the coracoid is also fractured, except there is a small bony fragment anterior inferiorly. The my regular radiologist was on leave on that day, so I asked him to come back and give me another picture that is an N-face picture, and an N-face picture cleared the whole doubts. So follow your instincts regarding the mid-range instability, and you can see there's a huge bone loss, which the osteotomy has already done by nature, and we went ahead with Latarche, and this is the picture of that particular patient after about 6 months regaining his full movements. So coming on the humeral side, the Hill-Sachs assessment, bony loss assessment, lots have been said about Hill-Sachs lesion. Many different X-rays views have been described, 2D CT, 3D CT, so on and so forth. But what exactly Hill-Sachs lesion is and what its role? Till date, it has been like FUFA, G in your family, but of late, the works of Itoi and Yamamoto has changed the entire concept. From 2007, everyone is roaming around that concept. So by definition, Hill-Sachs is compression fracture on posterolateral aspect of the humeral head, and it is present in about 40 to 90% of acute cases, and it is 100% accomplishment to a recurrent scenario. And the role of Hill-Sachs lesion in anterior shoulder instability is debated since long. It was first reported by Malgagny in 1855 and later on, after about a century, it has been christened as the Hill-Sachs by renowned radiologist Harold A. Hill and Morris T. Sachs in 1940 after their name. And it was in around 2000 when the importance of Hill-Sachs have been highlighted by the two stalwarts, Burkhardt and Jodevere, in their landmark paper, in which they have talked about that what Hill-Sachs is important, the Hill-Sachs is important when it engages. So many different X-rays, I am not going into the detailed views, their indices have been described to assess the Hill-Sachs lesion. The CT scan, all dimensions of defect have been calculated, and similar things were done by MRI, 3D MRI, and arthroscopy. I purposefully skipped off the various views for the sake of time. Coming to the pulse and pitfalls of pain radiograph, they have good diagnostic values of all the various views described to see the Hill-Sachs lesion. They have overall fair, good inter and intra-observer variation. However, in spite of all these, there are about 60% of cases when a Hill-Sachs lesion can be missed. And the most important thing about the X-rays that they are not the decision maker investigation. So coming to the workhorse is the 3D CT scan. And remember, again, a very important paper by Ho et al. In Journal of Shoulder and Elbow Surgery 2018. There is strong agreement amongst all the shoulder surgeons about the parameters depicted on CT scan. But remember, there could be an error in more shallow lesion, something like this. If you look at this arthroscopic picture, the radiologist has described the Hill-Sachs lesion from here till here, which is on-track lesion. But on arthroscopy, you find there is a small healthy cartilage island. And on the medial side of the head, there is another defect of the Hill-Sachs, which is engaging, or it's an off-track lesion requiring a different set of treatment. So the landmark paper, which came from Giacomo, which has given the concept of glenoid tract, which was a bit criticized by Schneider et al. For poor intra-observer agreement and difficulty in defining medial margin of lesion, for the cause that if you see in this particular posterior view of the humerus, this is the subscapularis, and the radiologist they have described the Hill-Sachs lesion from the cuff till here only, but there is some amount of medial flattening as well. So in shallow lesion, at times it becomes difficult, but most often this is the normal indices are well accepted. So this paper by Yamamoto, that is contact between the glenoid and humeral head in abduction, external rotation, and horizontal extension, is a concept which is being followed since 2007. And as we all know, that glenoid tract is located medial to the footprint of rotator cuff and is about 84% of the total or the maximum glenoid width. So the tract width decreases with the decrease in the width of glenoid if there is a glenoid loss, and hence increasing the chance of engagement of Hill-Sachs lesion. How do we decide to treat Hill-Sachs? If Hill-Sachs is within this tract, ignore that lesion. And if Hill-Sachs is medial to the tract, there are high chances of engagement that requires some sort of treatment. So there is an evolving concept of bipolar bone loss and Hill-Sachs lesion from earlier engaging and non-engaging lesion to on-track and off-track lesion, which has been described very nicely in this paper in Arthroscopy 2014. And the algorithm to treat the bipolar bone loss is something like this, which usually I do not follow, but it is like if there is less than 25% defect, which is on track, arthroscopic Bankart is the gold standard. Less than 25% glenoid defect, off track, arthroscopic Bankart supplemented with remplissage is needed. If the defect is more than 25%, it is on track, it is Latarjet is required. And if the defect is more than 25% on the glenoid, Latarjet with humeral side procedure, something like a remplissage or humeral bone grafting is required. What I follow is a recommendation from 2017 by Richard Friedman, in which they have reduced the bone loss. If the bone loss is less than 13%, standard arthroscopic Bankart repair is done. If the defect is 13 to 17%, and if it is on track, Bankart repair is done. And if it is off track, then Bankart plus remplissage. And if it is more than 17 to 20%, I'm already biased towards the Latarjet. If it is more than 20 to 25%, then Latarjet procedure is required. And if it is more than 40% of the total glenoid loss, we will probably require a iliac crest bone grafting or a distal tibial allograft to reconstruct that defect. So in summary, we have to identify high-risk patient, which is very critical. Remember, 3D scan is the main workhorse and gold standard for assessment of bone loss in recurrent shoulder dislocation. And this is a must investigation before contemplating the treatment. We have to understand the concept of bipolar bone loss, and there are many variables which determine the outcome of successful procedure. And Thank you very much for your kind listening.
Thank you, Dr. Arun Gupta. Now, the fourth talk is by Dr. Shivam Sinha. He's from IMS BHU. Topic is management of first-time dislocator decision making. Yeah, online. Yeah.
Am I audible?
Yeah, you audible.
Okay, thank you. So, at the outset, I would like to thank the Lucknow Orthopedic Society and UPOA for allowing me to present online my talk on management of first-time dislocator. We know that the shoulder is as unstable as this golf ball is. So we know that the overall glenohumeral joint dislocation is about 45% of all the dislocation of all the joints. And the incidence is high. And as the age goes down, it is about 47% between 15 to 25 years. And the second peak in an elderly with the low velocity falls. Males are more affected, 3 times more than females. And 9 out of 10 patients are between the age of 21 to 30 years. Posterior dislocation of shoulder is another rare injury, and this subset is about 4% of all the shoulder dislocations. What is the controversy when we are dealing with a first-time anterior shoulder dislocator? It remains regarding the imaging modality, method and length of immobilization after reduction, the risk of recurrence, and the role of early surgical stabilization. We know about the clinical feature of a shoulder dislocation. There is a square of appearance of shoulder, normal contour is lost, empty glenoid, bulge in deltovertebral groove. If there is a posterior dislocation, there is a posterior fullness and anterior flattening, and there is need for test for axillary nerve and brachial plexus. Coming to the radiography, as very nicely described by Dr. Arun, apart from routine AP and axillary view, we can have a scapular Y view to look for the acromion, striker notch view, specifically looking for the Hill-Sachs lesion, and a West point view to look for the inspection of anterior inferior glenoid. Because associated injuries do exist, there are greater tuberosity fractures, about 15 to 35% of patients. Even coracoid fractures are present in about 13% of patients. And depending upon the severity of the injury, the AC separation and clavicular fracture, they can range from 5 to 54%. Coming to the MRI, it is considered as a gold standard for evaluation of injuries of labrum, cartilage, and rotator cuff. However, the MR arthrography shown to be more sensitive than conventional MR. What if there is a first dislocation? If we have a fluid like hemarthrosis, a pseudo-arthrographic effect is seen without the use of contrast. Shoulder effusions aid in evaluation of labrum and ligamentous injury. And above all, if you do the positional maneuvers, you can get a good view for the anterior and posterior labrum. Like in abduction and external rotation position, you can have a fairly good idea of anterior labral pathology. And flexion, adduction, internal rotation, you can have an idea of capsular labral tears. A soft tissue bankard. Hello. A soft tissue bankard is the essential lesion for anterior shoulder dislocation. And along with this, chondral loss can be seen on an effusion-based MRI, and we can do the positional maneuvers as well. There are variants to the bankard lesion as well, and one of them is an APSA. And we can see also a very good, nice view of the glenoid cavity. And if you see in this anecdote, there is a huge amount of bony bankard, and the MRI picture of the glenoid, you can see a huge amount of bone loss in the glenoid. We can also have superior labral tears, and it has been found that 6 months after the primary dislocation event, there is a threefold increase in incidence of cartilage damage, as well as twice as many as slap tears are detectable in a conservatively managed patient. We can have Bankard and reverse Bankard lesion, which can be seen on MRI. And these are the Bankard variants which need to be evaluated specifically on MRI. Role of CT scan was very beautifully explained in the previous talk. And we need to study the fracture pattern. We need to study the Hill-Sachs lesion. We need to quantify the glenoid bone loss, even in the first dislocator. And there comes the concept of glenoid tracking. If the Hill-Sachs lesion is getting hinged even after a first dislocation, which can be because of a severe trauma, Hill-Sachs lesion more than 20 to 40% of the articular surface coming in the track of glenoid will predispose to further dislocations. So what are the consideration and management for a first-time dislocator? We need to know the history of natural history of primary shoulder dislocation, the effect of surgical intervention on natural history, the risk of long-term arthritis with and without the surgical intervention, and the immobilization technique post-reduction. Natural history, we know from time since now, as the patient age is lower down, less than 20 years, the dislocation rates are as high as 87% to up to 71% even at 5-year follow-up. But as the patient is increased at the time of first dislocation, the recurrence rate can be low as 16%. 20 to 40 years of age, they can have dislocation ranging between 50 to 60% for no reason why they are dislocating again. Reduction techniques, it has been advised that the first dislocation should be reduced without counter traction or traction and can be maneuver like mesh maneuver can be used. Immobilization post-reduction has been banged on by the Itoe study, which were done in 198 patients, and they found that first-time dislocation rate reduced to 26% when they were immobilized in external rotation, not in internal rotation as we conventionally do. And the logic they gave that there is an improved approximation of anterior labral tear to the glenoid that would lead to improved healing potential and reduction in redislocation. However, Sandoz, Cochrane's review, systemic review, and RCTs does not provide enough evidence in this support. What is the pathophysiology after acute dislocation? The scarring and retraction of labrum predispose to recurrent instability. This leads to a decreased static stabilization. Lax and unsound healing of capsular ligament predispose to recurrent instability. As the time passes, increased injury to surgical interval, the increased number of dislocation rate risks the factor for developing glenohumeral arthritis. Also, capsular tears and Hegel lesions, they do appear. Secondary intra-articular lesions, like I told, like slap lesions, they do appear after 6 months, and as the dislocation is neglected or not seen properly into chronic shoulder instability. Even when it is a first-time dislocator, or recurrent subtle shoulder subluxations are responsible for progression of intra-articular damage. Habermeyer has described in his paper that there are 4 phases. After acute dislocation, there is sequential loss of anterior hinges formed by labrum and inferior GH glenohumeral ligament, irreversible plastic deformation of anterior glenoid, and degeneration of anterior structure occurring by the 3rd dislocation, which they named as the point of no return. So, if the studies have also shown that patients who were treated non-operatively after first dislocation, they were having a 74% unsatisfactory outcome on Oxford Shoulder Score, even at 10 years. In contrast, who underwent surgery, 72% has better indication, better scores at 10 years. Aurelius, over 223 patients and 25 years of follow-up, they found that risk of arthropathy and arthropathy do appear in recurrent dislocators at 25 years with 40% patients. And those who just suffered one episode, even their arthropathy was there in 18%. Why do we need to see this very carefully? Because it is not only the arthroscopic Bankard, there are many other procedures which need to be installed. Because these are the relative contraindication, unless until you see it properly, even after first dislocation. A glenoid bone loss, the are inverted pear glenoid or engaging in a large Hill-Sachs lesion, even humeral aversion of glenohumeral ligament is a relative contraindication for this procedure. And this is the instability severity score, which help us to make a decision that if the age is less and the participation in sport of the person is and sports participation and on competitive gains, contact or overhead abduction is the main requirement. If the shoulder hyperlaxity is there, Hill-Sachs on AP radiogram, and there is a loss of contour or a loss of glenoid, then these patients are not the subject for an conservative treatment. They have to be operated. Which operation, that is to be decided upon these criteria. Management summary, the first dislocation is in young patient, and it is something to iterate by this slide, that if there is an evidence of large glenoid defect on initial imaging, somewhere around 10 to 15%, the patient is young, about less than 25 years, ranging 25 to 30 years, or a irreducible dislocation, dominant shoulder with continued apprehension in activities of daily living after first dislocation, highly active patient like those who take part in contact sports or overhead throwing, then these are the candidates where surgical intervention will benefit. However, if you are conserving them, then we immobilize in internal rotation for 2 to 3 weeks, but you have to keep an extended follow-up. So in conclusion, early imaging, MRA within 6 months of primary dislocation or high-risk patient like young male and in contact sports with shoulder hyperlaxity, they do benefit with appropriate surgical stabilization procedure to prevent further glenohumeral damage. But it has to be worked up thoroughly. This information is valuable for counseling patients about surgical and non-surgical treatment, and there is no concrete evidence support in either of the ways. Thank you.
Thank you, Dr. Shivam, for the talk. Now, the last talk of this session is by Dr. K.D. Tripathi, sir. Talk is on the retarded procedure. Dr. K.D. Tripathi, sir.
Good morning, friends. At the outset, I want to thank the organizers, particularly the team UPOA and particularly Dr. Ashish and Dr. Uttam for giving me this great opportunity to be here with the special event of UPOA. Friends, we all know that recurrent dislocation of shoulder, it is a not very uncommon event in our day-to-day clinics. And the arthroscopic Bankart repair is the gold standard treatment for this problem. But as the arthroscopic Bankart repair incidence is increasing, the complications as well are increasing out there. If these patients after Bankart, we have recurrence or again redislocation, I think that is a very challenging problem. If you do open Bankart repair, the recurrence is about 10%. But if you do arthroscopic Bankart repair, the recurrence is as high as 43%. The redislocation of the Bankart repair is basically dependent on the glenoid bone loss. If the glenoid bone loss is more than 25%, I think recurrence rate is more than 60 to 70%. But if there is only soft tissue Bankart lesion, recurrence is very minimal, and we can very well get rid of the simple arthroscopic Bankart repair. On the other side, if we have the bony lesion in the humeral head, Hill-Sachs lesion. Again, it gives rise to the recurrence after arthroscopic Bankart repair, but we can get through with the remplissage in these cases. The goals of surgery is to provide the very stable shoulder with the good range of motion, good functional outcome, and have the low complication rate and allow rapid rehabilitation, and it should be cost effective. What are the options? The anatomic arthroscopic Bankart repair is the gold standard. If there is Hill-Sachs lesion, we can go ahead with the remplissage, and we can address along with this soft tissue lesions like slap tear and HGL tear. But this Bankart procedure cannot address the large bone defect and the soft tissue deficiencies. For this, we have the non-anatomical repairs like putty plate, Magnuson stack, Eden Habinet, and all these Bristol Letarge. But they too have their own complications. They have the loss of motion, particularly in the abduction and external rotation. Even after Letarge or non-anatomic procedures, we have some premature arthritis, anatomy is distorted, and the revision surgery of these Letarge kind of surgeries are very challenging. In the original Letarge, we have seen that here just given single screw and a small portion of the coracoid that was not very stable. Letarge, I think, is mandatory even in this minimal bone loss of the glenoid, because if you have the bone loss, again, the arthroscopic Bankart repair usually sooner or later gives some laxity in the joint. The mini open Letarge is the ideal for these patients, because ultimately, when we develop the arthro Letarge, that is the gold standard, but till the time we are the arthro Letarge is quite difficult procedure and learning curve is very high. So mini open Letarge is in between the Letarge and arthroscopic procedure. The limited, we have in this limited deltopectoral approach, skin incision is just proximal to the coracoid up to the 3 to 4 centimeter of the towards the axillary fold, and then slightly medial to the coracoid so that we can reach up to the anterior inferior glenoid neck. We must do the thorough pre-op workup. Clinical and radiological evaluation must be done through the X-ray and MRI, and CT scan, 3D CT scan is mandatory for this patient to assess the glenoid bone loss and size of the Hill-Sachs lesion. Coming to the surgical technique, the incision is from the coracoid to the axillary fold. After having the superficial dissection, go to the deep. The cephalic vein is just retracted laterally along with the few fibers of the deltoid, and then open the cervix cap from at the junction of upper 2/3 and lower 1/3. Open the cervix cap and go to the capsule, do the capsulotomy. Erase the capsule from the glenoid neck, superiorly as well as the inferiorly. In the original Letarge, he used to cut the cervix cap, but here you have to split the cervix cap and then put the retractors over the neck of the glenoid, and then retract it horizontally, and then erase all the soft tissues from the glenoid and neck of the scapula. Make it raw, and then put the humeral head retractor and just expose the anterior and inferior part of glenoid very thoroughly. Then do the osteotomy of the coracoid. Just cut the coracoacromial ligament and pectoralis minor, and then do the osteotomy of coracoid. just proximal to the elbow of the coracoid. In the original Latarjet, he used to cut the distal to the pec minor, but here we just take about 2 to 2.5 centimeter of coracoid and then release all the soft tissues from the coracoid, and the undersurface of coracoid is cleaned. Then again, just take make a very good raw bone over the recipient bone of the glenoid, and then make 2 holes in the coracoid, and then put the guide. This guide is used just to flush the graft just parallel to the articular cartilage. It should not be proud from the cartilage, otherwise will lead into the early osteoarthritis. And then put 2 K-wires through this guide. Take out the guide after putting the K-wires, and then cannulated really use 4 mm in the proximal fragment and 3.2 in the distal fragment, and then cannulated screw up to 32 to 34 millimeter length. Approximately 34 millimeter length is sufficient for the fixation. And after sometimes you have a crack in the your graft, then you can go ahead with the small plates devised by some of the manufacturers. But usually plate is not required. Bone is quite hard, and you can get through with it. Then the closure is very important, because we have the ligament, coracoacromial ligament, and we can repair this ligament with the capsular abrasive structure. That is the Bankart kind of repair here. This is the first layer of checking. Then we can go ahead with the bony block, and finally repair the subscap. That gives the checkering effect of the conjoint tendon. This repair is very important so that the sealing effect of conjoint tendon is found. So 3 layers of protection is there. So in my opinion, Latarjet is superior in all respects than the soft tissue procedures. If you have even a smallest bone loss on the glenoid side, it provides very stable and very functional shoulder. The post-op rehab, the shoulder is immobilized for 2 weeks, and on 3rd week we can give the passive movements, and up to after 6 weeks we can mobilize actively, and patient can go ahead with the functional outcome and full function at 3 months. So in summary, Latarjet is superior to any other procedure if we have smallest bone defect, and it addresses both soft tissue and bony pathologies. Better result than the Bankart repair, especially indicated in young competitive sports players. It is cheaper than arthroscopic surgery because you need 3 or 4 anchors, and here only 2 AO cannulated screws are needed. So I think in all comparative studies, I think Latarjet is superior to the. Here are the few examples. This is a post-op patient of post-op X-ray of the Latarjet patient, and I think we have the good quality of function. This is the interesting patient. We did the Bankart repair. After 1 year, patient was epileptic. He had seizures, and he dislocated again after Bankart repair. Then we revised it and did the Latarjet. After say 2-3 years again, he came back with the dislocation of other side. Latarjet repair was so strong that he could not dislocate the repaired side, but other side was dislocated. So it is more stronger than the natural shoulder. And on the second side, he demanded directly that I will not go for Bankart again. I want to go with the Latarjet, and we did Latarjet, the bilateral Latarjet, and with the good functional outcome. Here is another patient. He is a 15-time dislocator, and patient had Parkinsonism with some neurological disease. He had some device of the deep brain stimulator on the same side, and the physicians and the nurses said you cannot use the cautery. So without using cautery, I think it was quite difficult to operate, but directly we just measured the on CT, it was more than 25% of erosion because patient was repeated dislocated 15, 20 times. So we directly went into the Latarja surgery, and I think post-operatively we did quite well, immediate post-operative after surgery. That is all the procedure of Latarja. Thank you. Thanks for the patient hearing.
Thank you, Dr. Tripathi, for talk. Now, this end of first session. I thank all the speakers, Dr. Neeraj, Dr. S.K. Srivastava, sir, Dr. Arun Gupta, Dr. Shivam Sinha, and Dr. Tripathi. Now we'll take discussion after the second session. Now I hand over mic to our organizer for the second session. Thank you, sir.
It was a wonderful first half of session one. I really thank Dr. S.A. Goel, sir, Sanjeev Avasthi, sir, and Ashutosh, sir, for sharing this session. Now I request M.S. Chabra, sir, Harish Makkar, sir, and Dr. Imran Akhtar, to please chair the next session.
Online. So friends, now I think the shoulder person from Pune, Dr. Ashish Bhabulkar, will be speaking on posterior instability.
Hi, good morning, everybody. Am I audible?
Yes, Ashish, you're audible.
Yes, lovely. Thank you, Ashish, Anup Agarwal, and team UPA-Con. Thank you for this invitation. I will speak on posterior instability over the next 15 minutes. The range of posterior instability is pretty wide, and you get different forms of format. So you can have, as you see here, a paralabral cyst, which is related to a posterior labrum tear, or you can have a posterior labrum tear in isolation without the cyst, and you can have a posterior dislocation where you can see a reverse Hill Sachs, and that can perhaps present as a neglected persistent posterior dislocation. Today, we shall not talk about the posterior dislocation because the session seems to be full of arthroscopy. So we will focus in the next 15 minutes only on the labral pathology. So here on this video, you can see a wrestler who's had an extensive posterior labrum tear, which is going on into the biceps. So this is a type 4 slap, which is extending into an anterior labrum tear as well. So this is a global tear. And these are patients typically seen in wrestlers, but most of the posterior labrum lesions that you see are usually related to epilepsy or electric shocks. So any patient with that history and who has relocated will come to you as an innocent shoulder, and on examination will be reasonably normal. You will not get the classic findings that you see in a conventional dislocator. Be careful in sports players, and occasionally you have road traffic accident patient to come in. The main complaint would be a vague pain, and they would just have that singular complaint of inability to throw. So inability to throw is a very significant complaint that one must take very seriously. The posterior apprehension test is commonly mentioned as the most common test for posterior instability. I find this sensitivity very poor, specificity is very high, and that's why you would also tend to do a couple of other tests. The O'Brien's test is non-specific because it will be positive in several other pathologies, including a Bankart, rotator cuff tear, and such. The jerk test or the Yankee test is one of the most reliable, more sensitive, very specific, and very often the patients will tend to do this test on their own themselves. So if you see a patient doing this test on his own, you can actually discern the head of humerus jumping over the posterior glenoid and creating that test positive. Here you will see another patient who's able to do this test himself. And you can see that he's relocating himself and dislocating himself on both directions. So, and you have this patient who can see it is riding the posterior labrum. And so unless we take out the shirt and get him to evaluate his instability, it's very common finding that would miss. So I rely very highly on the jerk test or the Yankees test on these patients. MRIs can be very telling. So here you can see that not only do you have a reverse Bankart tear or a posterior labrum tear, but you will almost always see a reverse Hill-Sachs. In the absence of a reverse Hill-Sachs, a signal in the posterior labrum should be suspect. You would often see a hemarthrosis in an acute posterior instability, and you'll see the detached posterior labrum. And the T2 and the T1 sag will show you an increased signal on the posterior labrum side. So I rely on the axials and the T1, T2 sagittal views on the MRI to give us this diagnosis. Sometimes the X-rays are a giveaway. You can see some little periosteal ossification there. But what is important on the MRI, apart from the posterior labrum tear, is to evaluate for the displaced center of rotation. The head tends to sink back posteriorly, and that's a very subtle finding, which is the classic for a posterior instability. You can get a bony avulsion here, but the association of the reverse Hill-Sachs is something that is that will nail the diagnosis on the head. Very rarely, if you have a bony fragment avulsion, a CT scan can be useful, but it is this center of rotation that gets displaced posteriorly is important that the surgeon be able to restore this. If it is associated with a periosteal sleeve avulsion, then that is called as a polpsa. When you see a young patient who has a unilateral isolated infraspinatus wasting and some vague symptoms of weakness of the cuff and inability to throw, you can just look at him and the diagnosis is shouting at you, this is a suprascapular nerve decompression at the spinoglenar notch due to a paralabral cyst. You don't even have to do any tests on these because no other condition can cause focal isolated infraspinatus wasting on these patients. So once you have a paralabral cyst, there are multiple ways of doing it. The orthodox treatment in the past used to be just do a CT guided aspiration and the pain goes away. Unfortunately, the instability will persist and remain there. And in the modern approach with the onset of arthroscopy, you can do an glenohumeral joint scopy and release the cyst indirectly without having to see it directly. And the modern approach now in elite centers would be to actually go subacromial, expose the cyst entirely in toto, and then remove and excise the cyst, and then repair the labrum. So this is an overwhelming classic paralabral cyst related to a posterior labrum tear. You should always observe that here on the bottom left, you can see the cyst in the spinoglenar notch and entering into the suprascapular notch at the transverse scapular nerve. So this will be a dumbbell cyst because it's a large paralabral cyst. It will need to be evacuated at two levels. So merely evacuating it at the spinoglenar notch indirectly through the glenohumeral approach is not enough. It has to be a drill to it on the subacromial side as well. For the nerve, we typically bring the scope from the lateral portal and then we bring an instrument through the Nevisor portal. What you see here is the trapezoid ligament, the conoid ligament, and as you drop down the conoid ligament, you would see the transverse notch where all the paralabral cyst lies there, and you decompress the nerve just lateral to the omohyoid muscle, which you see in red here. So this is the conventional technique where I have a scope in the anterior portal of the glenohumeral joint, and you can see that with the liberator, I'm liberating the posterior labrum tear. So you're seeing the entire posterior margin of the glenoid, and you can see the yellow typical synovial fluid coming out. So this is similar content as in a ganglion cyst, and you keep mobilizing till you are sure that the entire cyst has been decompressed. You cannot visualize a cyst, and you just have to do a guesswork here and imagine. Once you start getting bleeding, it's probably the end of the cyst because that is the hyperemic zone of the peripheral margin of the cyst. Alternatively, you could actually go in through the subacromial joint, identify the raphe between the supraspinatus and infraspinatus, and release the raphe. And here you see the cyst is just popping out, looking at you, inviting yourself for a complete excision. The advantage of this approach is you visualize the cyst and you can remove the entire dumbbell cyst in toto Like here, you see this is part that is on the suprascapular side, and this is on the infraspinatus side. So the dumbbell cyst has to be evacuated, and then you switch your scope back into the glenohumeral joint and then do a repair. This is the 55-year-old tennis player, and he's had a fall on his cycle, but he's had recurrent instability in the past without realizing that he had a posterior instability. He's come up with a posterior labrum tear, and you can see arthritic changes here. So because he's elderly, this is chronic, this is always a dilemma, because these patients get detected very late, because overtly, if you look at these patients, they're essentially normal. You need to have a very high index of suspicion in identifying them. So this gentleman on his CT as well, you can see the posterior cartilage changes. He's young, he's fit. So this is his 2-year follow-up, and you can see that he has achieved a reasonable range of movement, and he's happy. I have proscribed him, I have avoided allowing him to play tennis again, but he's doing his other cardiac activities, and he's almost got his full range of movement. Luckily, his pain relief is there. You can see a green TheraBand there in the background. He's been very diligent with his exercises, and so far in a 2-year follow-up, he's doing well. All we have done is an arthroscopic repair, and this is his 2-year follow-up on the MRI. We've got the entire posterior labrum healed. The cartilage changes remain there. Alternatively, if this was a younger patient, there are about 6 patients that we have done 2-stage. We've done a posterior labrum repair on the first stage, arthroscopic. At the same time, harvest the graft of the cartilage. And then at the second stage, 4 weeks later, we've done an ACI on these patients. But I reserve that for the younger group. 55 is probably not a good group to do this on. There's a wire media here in between. This is a 38-year-old chap with a similar posterior labrum tear, and you can see some cartilage changes. Now, these are not extensive. You can see that this is the center of the glenoid, the bare spot, and so he's got posterior labrum changes because of the delay, and this is the focus here on that. What I've done is placed my anchor far more medially inside on the glenoid, and we've covered that with labrum. Because this is not an extensive cartilage wear, this is a wire media that we have used in some of these patients. This is a 26-year-old general surgery resident. He's been missed because he had some vague symptoms, unable to play tennis. And you can see the MRI was also this is a 3 Tesla MRI, and you can see that there are some vague signals. It doesn't show a very clear-cut posterior labrum tear, but clinically he had a frank jerk test. He had failed his rehab. And if you see here closely on the axial view, the giveaway is that not only is his posterior labrum a vague tear, but his center of rotation is pushed back posteriorly. Now you must be alert, and this is a warning sign that he should have an arthroscopic posterior labrum repair. In the older days, 10 years back, we had metal anchors, and this is a global tear. This is how a repair would look. We've stopped using metal anchors now. I don't think it is warranted. We've switched to bio anchors, and that's much more pleasing to look at. But you can see the entire circumferential repair for this anterior, posterior, superior labrum tear. Lastly, in the passing, I must mention that there are subtle tears between a normal and a frank posterior labrum tear. This is called as a Kim lesion, where you need to probe the labrum, and you need to have a very high index of suspicion. And if these are typically seen in wrestlers who are unable to wrestle, you give them rehab and they go back and they come back to you. So you would use an arthroscopic repair for these subtle ones in athletes, but the younger ones tend to do reasonably well. Seldom do we have to use an external rotation brace. I reserve this for the posterior bony Bankards and the posterior neglected dislocations that we have done the modified McLaughlin procedure on. The conventional patients, once you've repaired them, I would most of them put them in the arm sling pouch. But if you have a shift in the center of rotation, which is posterior, then this is something that will help keep the head centered and take off the pressure from the repair as such. There's a volume of literature there. I've not gone into detail on the literature because of shortage of time, but if those interested can go up and check these articles out. In conclusion, these are much more less common than the conventional anterior labrum tear. 95% of our instability patients are anterior inferior labrum tears. So that's why they tend to get missed. The history tends to be vague. Clinical signs are not reliable. And that's why on the slightest suspicion, feel free to go ahead, get an MRI done. And if there's a cyst, then you have a double approach, either glenohumeral or a subacromial approach that I would prefer. Be careful in late cases. If you have arthritis, then you can deal with them either by repairing the labrum into the glenoid, or you could do an ACI or a microfracture. Thank you very much for your patient listening.
Thank you, Dr. Ashish, for a wonderful presentation on a very difficult situation.
Sir, very nice presentation, Dr. Ashish, sir. Sir, I wanted to ask that as compared to anterior dislocation, if there is a first time posterior dislocation, so is that patient is a more a candidate for a fixation as compared to anterior dislocation? Should we fix?
Right, I think that's a very interesting question. So if you're dealing with an athlete or a wrestler, for sure you would want to fix. If on the MRI scan you see that there is a posterior labrum tear which is clear cut, not a Kim lesion, and there's an associated reverse Hill Sachs, then it's a sign of an extensive injury. That means that the velocity of injury has been high, he deserves a fixation. But otherwise, posterior labrum tears, which are first-time presenters, do very well with the rehab program. I cannot say the same for anterior labrum tears, but posterior labrum tears can be conserved, especially if you're dealing with 40 years old. And as long as they're not athletes, they're ready to alter their lifestyle and avoid push-ups, gym, and sports, you can conserve them, but keep a watch on them.
Thank you.
Thank you, sir.
May I now call upon Dr. V.K. Pandey. He'll be speaking on frozen shoulder.
Thank you, Ashish, sir. I'll be discussing something about frozen shoulder. It's a common problem seen in OPD of every orthopedic surgeon. So it's an erratic increase in fibroblastic activity seen in the shoulder joint. Primarily, this is seen in diabetes, hypothyroidism, and inflammatory polyarthralgia. Secondarily, it can be seen in injury to the shoulder associated with cuff injuries or post-operative stiffness. It passes through 4 stages: the stage of pain, with stiffness, the stage of stiffness, and reducing stiffness, which is like inflammatory stage, which can last up to 3 months, and freezing stage, which can last up to 9 months, then frozen stage, which is up to 12 months, and thawing stage, which can be up to 42 months, means 4 years. So the treatment options which we most commonly follow in our practice is physiotherapy, steroid injection, mobilization under GA, and arthroscopic release. We can have other modalities as well, like cryotherapy, like electrotherapy, which we don't use most often. So I'll be discussing these 4 modalities only. Physiotherapy should be passive and active assisted, not too much of resistive exercises. Steroid injection is best suited for stage 1 and 2. Mobilization under GA is associated with iatrogenic injuries like fractures, because the bone is osteopenic, and cuff injuries can happen. Now, arthroscopic release is best suited for stage 3. So these are the advantages and disadvantages of the 4 modalities. Physiotherapy is a painful, long process, but usually it gives very good results and most of the patients respond. Injection is an OPD procedure, very cost effective, and most patients respond. It works best only in stage 1 and 2 when there is inflammation. If there is no inflammation, the frozen shoulder is set in, it doesn't work very well. Mobilization, it is a very commonly performed procedure, no incision, low cost. Arthroscopy and specialized skills are not required. The risk of iatrogenic injury is there, and post-mobilization pain may lead to re-stiffness again. So the recurrence of stiffness is there. Now, arthroscopy, it's a control release on the vision, which should be done for this, if this is stage 3 only. And you need surgical skills. One word of caution, arthroscopy in frozen shoulder is a tough job to be done. One has to be very careful when doing this procedure. So how do I proceed? So when there is only pain, I go with injection and physio. When there is pain with stiffness, I go with injection and physio again. When there is stiffness, mainly there is stiffness, less of pain, I go with arthroscopy, and I don't mobilize under GA. I've never done that. And when there is stiffness which is going down, so you have to just wait and watch and not to intervene. So these are the 9 steps which I follow every time when I release the shoulder. First is entry in the shoulder joint, which can be a problem in frozen shoulder. Then to create a working portal again can be a problem. Then goes to interval release, MGHL release, anterior capsule release, posterior capsule release, inferior capsule release, then fine tuning the release and confirm adequate release. So these are 9 steps. I'll try to take one by one. So entering the shoulder can be a problem with a thicker board, trocar and cannula. So try and keep thinner profile Wissinger rods to enter the shoulder joint and then reload your sheet over top of this. One can use a C-arm guided saline inflation of the joint because otherwise the needle is not going to enter the joint. You may be pushing saline here and there. So use C-arm to push in the saline in the joint and inflate and get some space. Slight manipulation, I only do flexion, no rotation because that may end up leading to a fracture. Traction devices can be helpful, but they are costly. One has to get it. And one should be very careful not to damage the cartilage, and the trajectory of the instrumentation should be correct because space is very less and one may end up damaging the cartilage of the humeral head. So that's once you have observation portal. This is the creation of the working portal, and one can see there's hardly any space for 16 gauge needle. There's very little space in the joint. So one should be very careful not damaging the cartilage, and the trajectory becomes important. Then gradual dilatation of the portal should be done using Wissinger rod, and on top of that dilator. So even dilator is not able to sneak into the joint. So the space is very less and the constraint of space is there. So we are looking at the left shoulder. So this is the space between subscap, biceps, head of the humerus and the glenoid. That's called as rotator interval space. And one should spend time to release this scarring. So once you release this scar, you will end up getting more and more space to work. So superior glenohumeral ligament or coracohumeral ligament, you have to release everything, whatever is between the biceps and the subscap. One should be very thorough with this procedure and should spend time on this. This is probably the most important part of releasing the shoulder joint, releasing the interval space. Less of shaver should be used for this procedure because shaver is an aggressive instrument, might have landed into a lot of bleeding and which might give the occurrence of scar formation again. So RF is the best device for this. Keep releasing all the tissue, and once you have released it, you have to start moving inferiorly. And the first structure one should release after releasing this is MGHL. MGHL in these cases are like fibrotic and very hypertrophied kind of. So once that is done, start with the anterior release. And once you have released the MGHL, you should start moving down. Important is to understand the adequacy of the release. And one should be able to visualize the muscle behind the capsule to think that the release has been done adequately. Otherwise, this release is not going to work. So once you have released the capsule, you should be able to see the muscle tissue behind. And with this, one should start moving down towards the recess. So it's basically interval tissue, then the antecapsule, and then the anteroinferior capsule. All along, one should be able to see the muscle tissue. So once this is done, one should switch on the portals and put in the observation port into the anterior cannula, and the working portal should be the posterior cannula. So one word of caution about the axillary nerve there in the axillary recess. I'll talk about that. So now the observation portal is the anterior cannula, anterior port, and the working port is the posterior one. And again, the same procedure has to be followed. One should be able to visualize the muscle tissue beneath the capsule. And once this posterior-inferior release meets the anterior-inferior release, you have completed the inferior release as well. Now, during this process, axillary nerve is at risk. So one should keep the RF probe facing towards the glenoid rim. And in this scarred inferior capsule, the axillary nerve is close to the rim. So one should stay very close to the rim, 1, and 2, the face of the probe should be towards the rim, not away from the rim. And as you release, Sometimes you might see axillary nerve also, like in this case. It's more or less 1 centimeter from the rim, but that's variable depending on how much scarring is there. The key is to keep the probe facing towards the rim and stay as close to rim as possible. And now you're there, you can see the axillary nerve. That's the nerve. So once the release has been done, one should try to fine tune the release. So anterior release has been done, posterior release and inferior release has been done. One should start with fine tuning the release. Any fibrotic band which is left should be taken off. Here I'm using the shaver, but the one word is of caution is that shaver is not the best device for this because it's an aggressive device and you should resort to RF probe only. So any band which can see, which is obstructing the vision of the muscle should be taken off at this stage. And the release has to be very thorough. So as the release is done, the movement of instruments become free and one can move on shaver and RF device all across the joint. So last step is to assess the release. So all around the release, one must be able to see the muscle tissue behind the capsule. So that is what the space looks like after the release. You can create a space by pulling some traction. And there's an easy movement of the instruments across the shoulder joint. So opening up should be possible with traction and muscle tissue should be visualized. And then you think that the release has been done adequately. So this patient opted to get the right shoulder release as well. This is MGHL. Usually you see MGHL like this. And in these cases, MGHL is usually hypertrophic and scarred and like cord-like. You sometimes have to punch it also. So this was the space on the right shoulder. Hardly you could put the trocar in the joint. And after the release on the right side, this was the space. Yesterday only I got the video of this patient doing activity or daily living. The frozen shoulder is 4 times more common in females than in males. So you see more the female patients than male patients. And they have this problem of undressing, dressing themselves. That is why they are really suffering with this. This lady has got both the shoulders released. And this is 3 months post-op. One word of caution is that arthroscopic release of frozen shoulder is a tough job and one might end up taking a lot of time to even enter the shoulder joint. And if one is not careful, then one might end up damaging the cartilage of the humeral head more than giving benefit to the patient. So the take home is physio is mainstay, still the mainstay. Arthroscopy is not for every patient. Steroid works very well in stage 1 and 2. Arthroscopy is gaining popularity gradually. For me, fixed frozen shoulder, when there is absence of external rotation and abduction, hardly any movement of external rotation and abduction, patient is exhausted with the physio, and there is failed previous manipulation or injection. That is the time when I think of doing a release of the patient. Mobilization is still popular. I have never done it, and there is a risk of iatrogenic injury. Thank you very much.
Very nice presentation, Dr. V.K. Pandey, sir. I want to ask, sir, that you give steroid injection all your initial first and second stage cases.
So now there are studies which have told that giving NSAIDs, so giving steroid along with physiotherapy gives better result, better pain relief as compared to NSAIDs and continuing physio without steroid. So in all my patients, I give steroid stage 1 and stage 2.
So if patient is a controlled diabetic, then also you...
No problem.
No problem.
No problem. Most of the patients are diabetic. They will go some time uncontrolled also, but then I give steroid in all the patients. Never had faced this problem of infection in the shoulder. That is the worry.
So, and regarding your patient selection for arthroscopic release.
So I've told you the three criteria.
Yeah, if a patient comes in directly in stage 4,
Stage-
fixed external rotation and abduction,
Yes.
and what you will first try, you physiotherapy or directly you will post?
So a patient has come to me at the stage of fixed frozen shoulder,
Yeah,
means no
fixed.
abduction or external rotation. But the patient is suffering. He must have undergone a lot of physio. So patient is exhausted with the physio. Some procedure has been done, some injection has been given, some mobilization has been done. Still the patient is stiff. Now you cannot wait more. So you do something about it. The only thing is one has to be sure that synovitis should be less. If there is a lot of synovitis and you attempt a shoulder arthroscopy, it will be huge bleeding and vision is going to be a problem. So one has to be sure that synovitis is less. It's a fixed frozen shoulder, more of a thickened capsule than inflamed capsule, inflamed synovial tissue. So inflammation should be less.
So is there a duration also?
No
Like,
duration.
Duration of the disease, like some cases the disease is self-limiting, the inflammation gradually subsided.
No, so for me, if patient comes with fixed frozen shoulder, lot of physio has been done, and some procedure has been done initially, some injection, some release, some mobilization. That's the time I tell patient to get arthroscopy done. So no fixed duration, 3 months, 6 months, no.
Okay, thank you, sir.
Doctor, what was the patient like? The bilateral shoulder, was it rheumatoid or something else?
This one?
This patient that you.
Hypothyroid. Hypothyroid. She was a female hypothyroid patient.
Any issues of instability after such a massive release?
No, sir, these shoulders are potentially stiff shoulders. So getting instabilities in a stiff shoulder, howsoever we may release is very less likely.
No, but once you have released such a massive thing like you showed the last slides which you showed. Now, after that, if you have got so much of a release,
Yes.
the mobility becomes much more increased.
Yes.
The patient is encouraged to do it more, like the lady you showed. She's trying all maneuvers. So is there any chance of unstable and dislocation or something?
No, so initially patient is not able to perform so many activities immediately after surgery.
No,
It's 3
but-
months down the line, she can do all the activities.
Yeah, but your last patient is hyperactive, I saw. Thank you very much, Doctor. Can I now request Rajkumar from Amravati? Please go ahead. Rajkumar.
Yes, sir. Thank you for the invitation. I thank the UPOA Association for inviting me to give my lecture on bio-SCR. And I thank my good friend Ashish for inviting me as well. I'll just share my screen. Just a second.
We can start, Rajkumar.
Sir, can you see my screen, sir?
Yes, we can see your screen and audible also. Go ahead.
1 second, sir. Philip Conall in his classification has told us about the massive cuff tears. And we know the dilemma associated with managing such massive cuff tears. The common tears that we see in treatment would be the type C and the type D. Type C involves the supraspinatus, infraspinatus, and the upper subscap. And the type D are where we see a massive cuff tear of the supra and the infra. We also are aware of a Gutierrez classification, which influences the management of a massive cuff tear. The type 1 to type 4 are the described classifications of fatty infiltration. The reason we should know this fatty infiltration has been highlighted by Gerber's paper, because after a repair of a cuff, there are some incidences where the fatty infiltration in the cuff reverses. But once it is stage 3 or stage 4, as Gerber and his team propose, there is less chances that the muscle can come back to a good quality. So in such a situation, does just doing a cuff repair will help is a question we need to ponder. We also should know how much of the cuff is retracted and it is at what level, because not every tissue can be pulled back to its normal anatomical attachment. And here, if you see, if it's a stage 3, it becomes a hell of a task to bring such a tissue which is retracted behind the glenoid to come back and sit at the level of its anatomical attachment at the top of the greater tuberosity. Ellman and Gartzman have given various types of classification. If you can see that the crescent shape, which is a very common type of cuff tear that we see. But imagine if you see a tear which you see on your right side on the screen here, the cuff is retracted at the level of the glenoid and the biceps is visible when you put your scope into the shoulder, which means that it is either a reverse L-shaped or a L-shaped tear. And we have a Herculean task at our hand to bring back the cuff to its near normalcy. I would like to share our case, which we did in our hospital here quite recently. She is a 70-year-old female. I would like you to concentrate on the mechanism of injury here. She had a slip and fall, meaning it is a traumatic tear. An active lady in her house doing all the housework now finds her that her sleep itself is disturbed, and most of the clinical tests are positive for the cuff tear. And if you can see her scores, they are not looking great either. So if you have to see the function of this lady, it is in this fashion. You can see here, her left hand is the one which is the injured hand. Active forward elevation is not great in this lady. She is not able to do her hair properly when she's combing. Although we can see that her comparable external rotation is there in the left shoulder. She will have difficulty to do a lift up like that. Now, when we turn and see, she has a reasonable range of internal rotation compared with the normal side. From the side view, if you can see again, it brings us to a conclusion that the limitation that this lady has using the left arm is quite significant. These are the still pictures of the same lady. I would not waste my time showing the same again. If you can see the acromihumeral distance in this lady, it is less than 7 millimeters, indicating that the shoulder probably would have migrated up. The cuff is retracted at the level of the glenoid here and probably beyond. And you can see that it is Gutierrez stage 2 and Philip Colon stage 3. Having said that, we proceed to do a double row cuff repair and add a biceps to the amount of collagen that can be used to enhance the healing. When we do a diagnostic arthroscopy, we see this. This is our long head of the biceps, and this is the level where the cuff is. We see a delaminated cuff tear in the shoulder, wherein we put tag stitches to bring the torn cuff and do a soft tissue release supraglenoid, as well as in the subscapular area, also in the subacromial area. You can see that the delamination of the cuff is seen here, and the whole of the head is bare without any attachment or the cuff being anyway close to the normal attachment. Once we release, we find that the cuff is still a long way to go to the level of the greater tuberosity. We proceed with the capsular release, very nicely done by Dr. Pandey in the previous talk, where he releases the frozen shoulder. That is a very important step when we try dealing with the massive cuff tear, because the shoulder would have contracted and the head would have migrated down. And when we release the capsule, the head migrates proximally and it becomes easy for us to bring the cuff back onto the head. This is nicely elucidated by the paper by Felix Savio in his paper. We now have a look at the shoulder and find out whether the biceps can be brought close to the top of the head, so that we can enhance the amount of collagen that is there for the healing. We mobilize the biceps and you can see it there, that it is coming up to the proximal part of the head of the humerus there. We put a tag stitch onto the biceps and fix it there in this fashion. And then we bring the cuff around the biceps. And at the final repair in the still image, you can see that this was how the head of the humerus was, bald in itself. And once we close the infra, which is this, and the supra, which is this, over the biceps, we can get a nice cover. Now I will take you through the surgical procedure, which is will take a little bit of a time. I will just speak through the presentation here. The head of the humerus is bald. We can see that the cuff and the joint is little contracted. The capsular release is being done, which is being shown here. The delaminated cuff is being cleared, and we try to understand the pathology in the shoulder. The releases are being performed meticulously. Tag stitches are applied to aid us in release of the tissues in the subacromial area. Once we have tag stitches, it becomes easy to go in and do the releases in this fashion. We do a bit of subacromial decompression. We clear the tissues on the head of the humerus. Now you can see that the cuff is coming barely to the articular margin of the humerus. So we plan a margin convergence suture to both the leaves of the cuff, the supra and the infra. And we also check if biceps can come and help us in, enhancing the collagen at the top of the shoulder. The margin convergence stitches are being taken. We also look at the delaminated part of the tear. In this fashion, antegrade suture passing is done. And once we tag the sutures on either side of the cuff and converge it, you can see that the amount of the defect on the top of the head is reduced. And now it will be probably a little bit easier for us to fix it onto the greater tuberosity. We bring the biceps in this fashion and fix it on top of the head of the humerus with a double loaded suture anchor, which is all suture. We also enhance healing by punching holes into the greater tuberosity to create a crimson duet as described by Stephen Snyder. Once the biceps is fixed, we put an anchor on the medial side, which will come in a while. We can see the medial anchor going in on the posterior side of the head of the humerus. Now we come through the infraspinatus and take most of the suture through the infra. Which is in this fashion. So once we get all the 4 sutures through the infraspinatus, we will now plan for a lateral row. A lateral row anchor is placed in this fashion, and you can see that the cuff will be dynamically reduced onto the greater tuberosity in this fashion. As we punch the lateral row anchor into the shoulder, greater tuberosity, you can see the cuff nicely comes back, and the sutures which are remaining onto the biceps are sutured to the infraspinatus. This enhances the hold on the cuff and increases side to side healing of the tissue onto the collagen that is there in the biceps. We again go on the supraspinatus side and take the suture in front, and again put a lateral row anchor on the other side and take the remaining sutures on the supraspinatus and fix it in this fashion. So once we have a reasonable fixation on this, you will see that the head is nicely covered and the cuff is sitting in a less tension fashion on the greater tuberosity. Now this is an option before we go into do something major like other kind of a supracapsular reconstruction, like using a fascia lata or a balloon procedure, which is a midway between doing something which is like a reverse shoulder. So preserving the joint would be an ideal option in such a scenario. Let us go and look at what happens to this lady post-op. So this is the video she has sent to us from her house and in the physiotherapy center. The scapula is stabilized and we have an assisted forward elevation of the shoulder in the beginning. And then she will be, as the scapula is stabilized, she will be able to do a forward elevation which is near normal. We have a protected range of movement for our external rotation. We don't want her to have an external rotation right now immediately. So she is able to do this much. A scapular kinetic chain exercises has been initiated and she is able to confidently move the ball up the wall in this fashion, and we are progressing in the right direction in managing this case. So this is the concept which Alexis Echelis Bostadius has rightly done and done a lot of research on this. I urge the August gathering to have a hand on this article and go through the nuances of how a biceps can be used to augment cuff healing, and we should not treat biceps like a vestigial organ in the shoulder. Coming to the rehab protocol, we will be highly protective of this repair for the first 6 weeks, and it will be only assisted movements that we can allow. Probably after this, in the second phase, probably after the 7 to 12 weeks, we will allow active movements in the shoulder. Strengthening exercises and range of movement exercises will begin probably after 3 to 4 months. And thank you very much for allowing me to present this case in front of you. Thank you, Team UPOA. Thank you, sir.
Thank you, Dr. Rajkumar, for a wonderful and fascinating surgical procedure you showed. That is very clear and very nice. Thank you very much.
Thank you, sir. Thank you very much, sir.
We come to the end of this session. Thank you very much for the listening. Are we okay? We have the discussion. Delegates are invited to ask questions from the panels. Is there any questions? Comments? That's clear. Thank you so much.
Dr. Rajkumar,
Sir.
for how long can you put the arm in the abduction splint?
Sir, at the moment, we are allowing her to have only passive assisted movement. She is in a shoulder immobilizer, but she is allowed to do her activities less than 90 degrees of shoulder abduction. So if you have seen through the slide, she is being assisted in her shoulder elevation and her external rotation is still in the protected mode. We are working on the scapula movements, and once we get a good stabilization of the scapula, we will allow her to do her forward elevation and other external active movements of the shoulder. And that is quite a while from now because she is hardly 2 months down the line.
Sir, what are the indications of this reattachment of long head of biceps tendon, and what is the relation of the attachment site in relation with the rotator cuff?
Great question, doctor. There are two things here. One is biceps in continuity sometimes has a part of its capsular attachment, which will enhance us to utilize that thing to enhance the cuff. especially when we see that we are not able to bring the anterior part of the cuff onto the greater tuberosity. This gives us additional collagen tissue to suture and to improve our healing of the cuff. Having said that, there are two ways to use biceps. One is biceps can be used in continuity. Second is you can do a biceps tenotomy at the top of the groove. I generally prefer to use biceps in continuity if it is of good quality, because biceps in itself has got a shoulder depressor function. It will not allow the cuff to, it will not allow the head to migrate proximally. Secondly, when the biceps is intact, the labrum also will be intact and it will enhance the negative pressure of the shoulder, which helps us to stabilize the shoulder in a better way. So these are the two ways we can use, either doing a tenotomy or a translation of the intact biceps to the attachment little posteriorly so that the cuff can be closed. It is also important for us to, stitch a part of the cuff, especially the infraspinatus, onto the biceps so as to restore the force couple between the subscap and the infraspinatus and balance the head of the humerus on the glenoid to get an effective elevation of the shoulder. Hope I am clear with my answers, doctor.
Yes, sir. Thank you, sir.
I think, thank you. Close the session now, and there will be the second session. May I invite Dr. Saini to please announce the second session.
Thank you, sir. Thank you for having me. Thank you.
It was a wonderful session for the basic shoulder arthroscopy. Now I request Professor G.K. Singh sir, Professor Dr. A.K. Srivastava sir and Dr. A.K. Srivastava sir to please share the next session. The next session is on shoulder trauma.
Thank you, UPOA. Thank you, organizers. We bring greetings from Devbhoomi. The trauma session starts. Dr. Roshan Wade, Dr. Deepak Bhatia, Dr. Sandeep Gupta, Dr. J. Maheshwari, Dr. Sachin Avasthi, and Dr. Sandeep Garg are the speakers today. So decision making in rotator cuff tears, Dr. Roshan Wade. He must be speaking online. Please put on Dr. Roshan Wade.
Yes, can you see my screen? Hello?
Yes, Roshan, we can see.
We can see it.
Is it okay? Yeah. If you can see my screen, I'll proceed with the talk. If moderators allow me.
Dr. Roshan, we can see your screen. Please go ahead.
Yes. So my talk for the day is arthroscopic rotator cuff repair and different strategies, how to bail the situation. And the strategies could be divided depending on your etiology and pathogenesis of the disease. The most importantly, it is the cuff associated with the stiffness where the patient presents to us. Associated acromioplasty and the pain regenerators in the shoulder joint, especially the bicep, which previous speaker has already spoken upon, needs to be taken care of. And then you can decide a strategy depending on your tear pattern, whether you have a partial tear or full thickness tear. If you have partial tear, if it is a bursal side tear, it's a different strategy. If it's an articular side tear, then it's a different strategy. Small to medium tear, we will have a different plan of working, and the large and massive tear, especially the irreparable one, will have a completely different type of strategy. So one has to understand the disease and the pattern of rotator cuff tear before you plan the surgical repair in any case. So what is the current literature which is evident on the rotator cuff repair? When you see the partial cuff tear, there are equal outcomes between in situ repair versus the complete repair. The full thickness, one has to plan either a double row or single row. Literature wise, double row has shown a very good result as compared to the massive retracted cuff tears. And partial tear, whenever you see a massive irreparable tears, and sometimes one can plan a tendon transfer or the other strategies. So what has changed in last 10 years as far as rotator cuff is concerned? If you consider the rotator cuff repair in early 90s, that used to be a single tendon repair, that is a single footprint repair or single anchor repair, and where it was a completely partial tear. If you do a lateral side single anchor repair, you are actually creating a pasta type of lesion in this situation. So what is important here is to understand that Japanese author Mochizuki from Japan, he has demonstrated that there is a attachment of supraspinatus onto the lesser tuberosity as regards to the greater tuberosity, where it has got 80% attachment and 15 to 20% attachment that goes on lesser tuberosity, creating a pulley which goes above the bicep tendon, and then you have a maximum representation of infraspinatus onto the tuberosity. This explains why you have the U-shaped tear whenever you see a rotator cuff tear in your clinical practice. So what are the strategies which can be used for repair as regards to a standard single and double row repair? I think it's very important to understand what is a standard repair, which we have practiced for years. This is a standard repair where we have placed an anchor on medial side and then try to repair the rotator cuff back to its normalcy. In single row repair, again, you do a same thing where you do only a single repair, that is single medial tendon repair, and then the lateral row repair is where you repair the lateral side of the tendon so as to create the anatomy as it is a complete anatomical repair of the tendon. So let's understand another strategy, that is diagnosing such patient. MRI remains the mainstay. And once you have these MRIs and you have planned the repair, you can plan it either in the form of maximizing the repair strength. First, importantly, one has to diagnose this disease or these tears. One can plan a diagnostic scopy. You can exhibit bursal or articular surface tendon tear depending on your diagnostic scopy. If it is a bursal surface tear, you can plan only bursal surface repair, like in this case where we have done anchor fixation on the tendon that is on tuberosity, and then we try to do a double row type of bursal repair where you can get a complete repair back to its normalcy. It is important to note that whenever you place your anchor, you should place it very close to the medial attachment of the rotator cuff onto the tuberosity for any bursal cuff repair to be more anatomical. And then once you fix it with the help of sliding knots, then it can go back to its normal position. With the help of lateral anchor, you can fix it onto the tuberosity. So this is the strategy for your simple bursal surface side tear, which can be very, very painful at times and which can give you a complete bad result. So what is important in rotator cuff surgery is identifying your bony landmark. The most important bony landmark is the tuberosity, that is where the attachment of rotator cuff is. Second is acromion, and third is the spine of the scapula. Because unless you do this anatomical landmark study, you cannot decide upon your strategy what kind of repair is needed. Take a second consideration of article sided tear. As you can see here, there is a completely articular side tear. The lateral side of the cuff is intact, and as you
Dr. Roshan, can you hear us? We are not able to hear you. Dr. Roshan, we are not able to hear you. So it seems that the connection of Dr. Roshan Wade has lost. So we can switch on to the next speaker, Dr. Deepak Bhatia. Joint preservation strategies in rotator cuff tears. Dr. Deepak Bhatia.
हाँ ऑन है फुल है पूरी
Will he be speaking live or recorded? Okay.
started by now. There's no reason for it to not start.
Hello.
Is that the associated supraspinatus tear should be repairable. The upper 2/3 of the pectoralis major is harvested and is rerouted under the conjoint tendon to recreate the subscapularis vector. The tendon is then attached to the lesser tuberosity and provides good functional outcomes. The lat dorsi tendon is used for irreparable posterior superior tears. The prerequisite is that the subscapularis should be intact and the teres minor should be hypertrophic. The lower trapezius transfer is a new tendon transfer. The only disadvantage here is that the tendon length is inadequate and a bridging allograft is necessary to attach it to the humeral aspect. Middle trapezius transfer is a new transfer that is currently under evaluation. It involves dissecting the middle trapezius from the acromion, and the tendon is then rerouted under the acromion to attach it to the tuberosity. For combined deficiencies, I generally use the pectoralis major, the teres major, and the latissimus dorsi tendons. The pec major tendon again is rerouted under the conjoint tendon and attached to the tuberosity, and the lat dorsi and the teres major are rerouted posterior to the humeral head and attached onto the anterior aspect to provide external rotation. Lastly, the balloon spacer is a salvage option in irreparable tears. The synthetic balloon can be inserted and insufflated in the subacromial space and provide superior stability to the joint. However, the outcomes are unpredictable and there are problems with spacer degradation, so this is not recommended for routine use currently. So in summary, massive tears without arthritis, joint preservation is mandatory. More than 90% of the irreparable tears can be repaired arthroscopically. Bio-augmented repair is a good option for weak and degenerative tissues. Subacromial bursa and biceps are biologically active grafts and should be used for biological augmentation. The superior capsular reconstruction has shown good outcomes. However, the complication rates are high and tendon transfers and spacers have unpredictable outcomes. Thank you.
Thank you. Our next speaker is Dr. Sandeep Gupta. Dr. Sandeep, can you hear us? Welcome, Dr. Sandeep. AC joint injuries treatment options.
Good afternoon, everyone. I'll be speaking on acromioclavicular joint injuries. So first we'll go to the anatomy. It's a diarthritis joint. It has got a cartilage and a fibrocartilaginous musculoid disc like a meniscus in the knee. So AC joint contributes, acromioclavicular ligament contributes almost 90% of the anteroposterior translation. So here you can see this is a acromioclavicular ligament and it consists of a superior capsule and superior ligament, posterior ligament, anterior ligament and inferior ligament. So there are 4 ligaments are there. It's a very strong ligament. And other ligaments are the coracoclavicular ligament, which has got 2 parts. Conoid part, which is more medially, posterior and medially, and a trapezoid part, which is more anterior and laterally. And this is very important for the vertical stability. Besides this, there are the dynamic stabilizers like deltoid muscles and trapezium is there. So once the injuries occurs, these gradually each ligaments or the muscles starts tearing off. So what is the etiology? Almost 9 to 12% of all the shoulder injuries are AC joint injuries, but most of them are like grade type 1 to type 3 and they are either ignored or neglected or they are not diagnosed. So it's more common in males, about 20 to 30 years, more young athletic people. And what is the mode of injury? Is basically force depression. It is basically the lot of forces applies on the acromion and the shoulder girdle rather than the clavicle is pushed up. It is basically the shoulder girdle is pushed down. So injury starts from AC acromioclavicular ligament. So initial injury will be the sprain of the ligament, then gradually it will go to the coracoclavicular ligament and then the muscle will tear off. So this is how the grading of types of dislocation will be there. There will be a lot of associated injuries might be there, almost 18%, especially in higher grade injuries like grade 3 to grade 5, and slap is the most common injury. So what is the diagnosis? Type 1 to type 2 may be neglected and ignored. There will be some pain, patient may come late, presentation will be there. But from 3 onwards, there will be definite swelling will be there. The piano key sign will be positive. There will be ballotable lateral end of the clavicle. Cross body abduction will be very painful. You can have anterior posterior translation of acromion, of clavicle. So X-rays, trauma series of shoulder should be done. AP view, most important is the Zanka view, that is 15-degree cephalic tilt, and it should be done a bilateral so that you can compare the CC distance. And lateral axillary view is more important in grade 4 injuries. So it is the Rockport classification is there for all of you are aware. There's a type 1 injury where only the sprain of the AC ligament is there. So it is hardly like few fibers are torn. And type 2 is when whole AC acromioclavicular ligament is torn and partial torn of the CC ligament is there. So the CC distance is about 25 of the normal side, more than 25%. Here type 3, it is almost 25 to 100%. CC distance is increased compared to the contralateral side and both the ligaments are torn. Type 4 is basically posterior translation of the clavicle. It is posteriorly displaced. So you need an axillary lateral view for this injury. And type 5 is a more than 100% CC distance compared to the other side. And type 6 is a dislocation of the clavicle, either subacromial or subcoracoid. So it is here the CC distance is reduced compared to the all other injuries. And the management will depend upon these this classification. So the management in type 1, type 2 is very simple, conservative management, ice packs, analgesics, slings, and early shoulder mobilization. In type 1, after maybe 5 to 10 days only, you can start mobilization. Sling is also off. And type 2 injuries, it could be for 2 weeks or so. Type 3 is a controversial, whether you should treat it or not. Most of the time, type 3 is also managed conservatively, like above, but the immobilization period will be like 4 to 6 weeks. But in cases patient doesn't improve, or patient is very high demanding athlete, or a large laborer, heavy laborer, and those who do overhead activities, these patients may be considered for surgery. So this is a article discussed in the code 1998, that management of type 3 injuries, conservative versus surgical therapy. And most of the articles have shown that there is no advantage of doing a surgery in type 3 injuries, especially this high demanding or patient has not responded. The complications are more compared to, and there is no point, there is no recovery, like early faster recovery is also not there even if the patient is operated. So there seems to be no reason to recommend any operative treatment for type 3 injuries. So this is again, a lot of articles are there, which is there is no advantage of doing surgery in type 3 injuries. So surgical management is for type 4, type 5, and type 6. There's a lot of various methods are there. We have seen over the last 20-25 years, Bothwa screws, Femister technique like K-wire fixation. Any fixation across the AC joint is likely to cause a lot of AC joint arthritis. So passing the screws or circular tension band wiring is not recommended. And Bothwa screw is also out now. So initially we have used, like last 10 years back, we were using hook plates. And since in military, a lot of all the AC joint type 3 also we were operating and putting hook plates so that patient goes back to military duties, especially the right shoulder patient needs for firing and military duties, they need good fixation. And so here you can see there's a type 3, type 4 dislocate and type 5 dislocation. There is fixed with the hook plate. After 3 months, you can see some amount of lysis is there, and the plate was removed after 3 months. Still it is holding, but late complications are there. Either the reduction is lost over 6 months to 1 year, and there is acromial fractures are there. AC joint arthritis in 40% of cases has been noticed. Acromial osteolysis if plate is continued for a longer duration, and definitely a second surgery is required for hardware removal. So this is again not in vogue now. And Beaver and Dunn has done this procedure in 1971. Basically, this was not an anatomical procedure. A CA ligament, the acromioclavicular ligament, was used to substitute the CC ligament, which is not very strong. It is almost just 25% stronger, as strong as CC ligament. So it was not providing any horizontal stability also. People have modified this technique, Beaver Dunn, the fixation of the CC ligament with the screws, with the endo buttons and ligature. But again, there is no horizontal stability is there. So this is again out now. What is coming is a anatomical CC ligament reconstruction. Initially, like last 5 years or so, there was screws, sutures and buttons like endo buttons. Initially, it was only the tightrope technique, one tunnel in the clavicle and one in the coracoid. So it was not an anatomical, because you know there is a trapezoid and the conoid ligaments are there. It is one in one plane you are passing the screw. So there was a lot of almost 30 to 40% patients were having translational stability, like posterior translation of clavicle was there. So this is what I was doing. making both ligaments simultaneously. Like you drill a hole, one endo button is passed in the coracoid, and this is your lateral side, this is your medial side. So the medial, the conoid part, the drill is done more from posterior to anterior. So it is posterior to anterior. So you are trying to recreate the ligament. And here it is more anterior and lateral. So the drill is done anterior to posterior. So once these are passed, that separate, like I was modifying this from the tightrope, you have got only 2 buttons. So I was passing another fiber tape into one of the dog button or the ABS button and putting it and reconstructing both the ligaments. So this is how you can see one button is here, one is here, and you can confirm in the C-arm the reduction is there. So this is the endo button lying below the base of the coracoid, and these are the 2 dog buttons. So the clinical type 5 dislocation and immediate post-op, well reduced. Another case, this is after 6 months, the joint is well reduced. So now again, the changes are there, that you are doing 2 drills, lot of chances of fractures will be there, coracoid fractures or the clavicle fractures. So, and it is not very anatomical. So we need some graft. So either the allograft or the autograft. Either most of the time we are using semitendinosus or gracilis or a palmaris longus. Since patient under same anesthesia, you can take the palmaris longus. So this is a semitendinosus. So initially the fixation is done with a single button for reduction, and the semitendinosus is looped around the coracoid, and the axis of the semitendinosus is passed to the acromion, through the acromion. This is again the internal bracing of the acromion done, because many times we have seen there is no horizontal stability with if you are using a single button and a loop also. So need to address the AC joint fixation also. So there's the immediate post-op X-ray. Here's the dog button. This was fixed. Internal bracing was done with the bio anchors. So the current trend is arthroscopic CC ligament reconstruction with a loop autograft. Why loop? Because you have to drill 2 holes and pass a semitendinosus tendon. The chances of fracture, the osteolysis, and later on will be a lot of problem will be there. With the Indian bones, the clavicle is also very thin. And simultaneously addressing the acromioclavicular ligament by the either internal bracing, or if your ligament is axis, you can pass through the acromion and resuture it or fix with a suture anchor. And people who are doing arthroscopic procedures, they can simultaneously address this intra-articular lesions also, which you have seen slap lesions can be there. So other techniques are like if you are worried about the tunnels and all, this is a 2 metal anchors can be put, one for the trapezoid, one for the conoid, and a small drill holes, only 2 mm drill holes. You can pass a number 5 wire and suture it like this, and similarly for the AC joint. So it is total anatomical reconstruction. In acute situation, you do the repair will be very successful. And if you don't want to do any tunnel, one tunnel only, you can cross this semitendinosus, pass it again through the acromion and resuture it. So addressing both the ligaments. All these surgeries are with complications. AC joint arthritis is the most common over the period of time. Scapular disc kinesia, sick scapula syndrome, fracture of the clavicle, coracoid, and acromion are there, especially with the older implants, and implant failure will be there. Infection, rotator cuff injuries, and adhesive capsulitis if you have immobilized and do a lot of dissection. Thank you very much.
Thank you, Dr. Sandeep. The discussion will be at the end of the session.
Thank you very much.
Our next speaker is Dr. Jitendra Maheshwari. He must be speaking online.
Yes, I'm speaking. Sandeep, if you can unshare, yes. So I'll share my screen now.
Thank you, Dr. Maheshwari.
Thank you very much. And can you see my screen?
Not yet.
How about now?
Yes, we can.
You can see, you can hear me, right?
Yes, yes.
Okay, I can proceed then. Well, thank you very much for inviting Dr. Ashish and UPOA. And I'm very pleased that some of my good friends are also there. Sanjay is there, Roshan is there, and all other people. It's very interesting when you speak on a topic 10 years interval. So I digged out my talk, which I gave on this topic about 10 years back. And that gave me an insight into how things have changed in 10 years. Very interesting for me to learn that. So for basic, how common is it? Let me tell you, it used to be very common about 8-10 years back. I used to get a lot of neglected anterior posterior dislocations, but somehow they've disappeared. The reason maybe they're being diagnosed, CT has come into the vogue, or whatever, but the number has definitely gone down, which gives me a comfort that these are being diagnosed out there in the periphery. Anterior dislocation, yes, sometimes get missed, but not that commonly. But it is the posterior dislocation which is missed much more often. Now, how not to miss? That's the first thing I want to give a message, particularly to the youngsters who are sitting there. You must have a high index of suspicion in a shoulder injury. When there is no bony injury. I remember my PG days, we will see the X-ray, no bony injury, send the patient home, not even examine the patient. If a no bony injury patient is not recovering within 3-4 weeks with usual normal physiotherapy, suspect something is wrong. Maybe the X-ray you have not seen properly. So-called frozen shoulders, because often the injury is very minor and patient comes to you with a stiff shoulder. The X-ray, either it is not done, or if it is done, it's not a good quality, but the patient is not responding. Stop, think, maybe you're missing something. Sometimes the X-rays are vaguely not looking okay, not done properly, or maybe they're not looking okay. Stop. Maybe do another X-ray, maybe do an axillary view, or do a CT. In polytrauma patient, often because the attention is to major fractures like femur and other places, and especially post-seizure, patient is unconscious. Here, the shoulder injuries of the kind of dislocation are often missed because these are deep joints and you really your attention is not there. Old age patient with dementia, Parkinsonism, obviously they are not able to complain anything. And these are the areas where you can miss these injuries. And if you're a little more careful, it is in your mind, you can look at your X-rays again and have a high index of suspicion and do necessary investigation, for example, CT, and it's not difficult to diagnose at all. Now, let me talk about anterior dislocation, which is not very common. And the question comes, till how late can you do a close reduction? So in anterior dislocation, I would say it's very, very dangerous to reduce them closed without anesthesia after a week. And even under anesthesia, if the patient is a little bit on the other side of 35-40, one should be very, very careful to try a close reduction because you can create a fracture. So my own threshold is 1 week. In elderly people, under anesthesia always. In young people, I may try, but I'm very careful about close reduction in an anterior dislocation. I'm more liberal with posterior, as I will tell you a little later. Treatment, if it is not reducible, you have taken the patient to the OT, it's not reducible. Now, what do? Do nothing. Who are those patients? Elderly patients, not much symptomatic. Somehow, funnily, the range of motion and functions in an anterior dislocation neglected are much better than in a posterior dislocation. The reason being, they still have some amount of external rotation, some amount of abduction, and they can be manageable. Unlike a posterior dislocation, where their external rotation is completely lost and they cannot manage, because if you don't have external rotation, you can't do overhead functions. So anterior dislocation neglected can be surprisingly very functional, and particularly in elderly people, one can just leave it as it is. And this is what used to be 10 years old slide, where do nothing in most of the cases, because even the results of surgery was full of complications. So this was 10 years back, but it has changed now. So if the patient is symptomatic today and is a young patient, one would try to restore the anatomy by doing surgery. Now, what are those surgery? In somebody less than 60, 65 years old, youngish person, good quality bone, I would like to restore the anatomy by doing open reduction and putting the head back to place, because I know it can maybe give immediate good functions. And also the patient is, future possibility of any kind of surgery like replacement later on is possible. But again, it's a very technique dependent surgery, where it's a demand oriented surgery, because sometimes the functions of a unreduced dislocation is good enough, and whatever you may do may satisfy your ego of having done a good reduction, but surprisingly function may not be much different. So one has to take a call patient to patient basis. When it comes to elderly people, this option wasn't there 10 years back in my slides, and reverse shoulder replacement today is a very good option if a elderly person is actually disabled, symptomatic, rather than trying all kind of open reduction, etc., etc. I think reverse is a very, very productive surgery in elderly age group when you have a unreduced anterior dislocation. Now, tips for open reduction, some tips. Before you even take the patient to the OT, you must see where there is an anterior glenoid loss, which sometimes happens because of persistence of dislocation. You know, the erosion of the anterior glenoid happens, and if you're not ready with taking care of that erosion, you will end up with recurrence. Exposure is sometimes very difficult. You have to do a coracoid osteotomy, get everything out of your place. And the key to surgery is actually identifying subscapularis, because the head is in such funny shape that you cannot find the subscap, and you have to externally rotate, find the biceps, find the subscap attachment, mobilize it, because subscap identification and repair subsequently is the key step of this surgery. And of course, once you have taken the subscap off, you have to do quite a lot of extensive capsular release. Anteriorly, not much of a problem, but inferiorly and sometimes even posteriorly, because all the posterior capsule gets attached to the head as well as to the glenoid. And sometimes it is very, very difficult to get the release all the way down. And unless you do that, you cannot have a stable reduction. The reduction should be at the end of it very effortless. You should not be pushing it and purposely putting a K-wire in there to keep it there. That will not work. Either it will make the shoulder stiff or the shoulder will come out again. So your releases have to be good enough that your reduction is more or less effortless. And subscap repair to keep it there is also very important, and that may sometimes need reinforcement from the front. Of course, you have to immobilize these patients either internally with the help of some K-wire from acromion down to the head, or even external immobilization is required for 6 weeks, and then you rehab them. So if you are taking up a patient for open reduction, these are the critical steps. And the most critical is identifying subscapularis and keeping it safe enough to be able to suture at the end of the operation. Now, when you are doing replacement for these neglected anterior dislocations, hemiarthroplasty used to be done in the past, but totally a disaster because it cannot be kept there. The tendons that you put around the hemiarthroplasty stretch out, and it becomes a nightmare to have that, hemiarthroplasty floating in the shoulder somewhere and causing more damage than benefit. So it's out. One procedure which is out in a neglected anterior dislocation, in my view, is hemiarthroplasty. I would rather do a reverse shoulder replacement if patient is in the age group of 65, 70, and that really works very well. Now, I come to posterior dislocation. These are more commonly neglected for a simple reason that X-rays can fool you. Look at this X-ray on the right. It just looks like a normal X-ray. Sometimes radiographer take in internal rotation and it can just fool you. But if the patient is not improving, you suspect, take another X-ray, do an axillary view, do a CT scan, and it's not difficult to miss these things. And now with the availability of CT scan, actually the incidence of missing these fractures or dislocations have gone down. I think that's my take, because I don't see so many of these now. Now, clinical examination, if you are interested in doing, a lot of us don't do it. There is a bump there. The most important point is restriction of external rotation. All other movements will be more or less normal. Forward flexion, internal rotation, everything will be normal. But restriction of external rotation so severe, it will not be even going to neutral in more often than not. And that kind of a severe restriction can only remind you of a bad frozen shoulder or a very severe osteoarthritis. But worst is in posterior dislocation, where it cannot go even to neutral. Now, you can always do further imaging, and axillary X-ray is always possible in a neglected thing and can clinch the diagnosis. But CT scan is the real thing that you should do, and it'll give you a good idea about what are the injuries, where is the bone loss, and if you do want to do some surgery on them, CT scan is a must. No MRI. I think MRI has more or less no role. Yeah, sometimes if you suspect, you can always do it, but more or less my preference is to do a CT scan because it is mostly reconstructing bony anatomy and not the soft tissue anatomy. Now, as far as treatment is concerned, again, the question in a posterior dislocation, till what time can I try a close reduction? And in my books, even till 4 weeks. In fact, one I could even reduce at 6 weeks to my surprise. And it all depends on how bad the dislocation is. Sometimes it is just lying just around there behind the posterior lip of the glenoid, but sometimes it is all the way behind. But I think if it is not very bad posterior dislocation, not lying all the way behind, one can try a gentle manipulation in a young person, not in an old person. 4 weeks is my cutoff, where when I take the patient for open reduction, I do try a close reduction just as a hook. And if that happens, it is very simple to mobilize them in some kind of external rotation brace, or this is a homemade brace. You can put a thick padding in the axilla, because sometimes these braces are not immediately available, but that's the time, and you can then switch to braces later on. Now, treatment if posterior dislocation is not reducible, again surgery, and it is a good surgery. I think it is a very good outcome surgery. And in anybody less than 65, 100% surgery works very well in all kind of pathologies, and I'll show you some of the cases. Again, when the patient is a little elderly, maybe 65, 70, I start thinking whether I'm going to give a good result and quick rehabilitation and do a open reduction. Rather, I would sometimes choose reverse shoulder replacement in a selected patient. Now, if it comes to open reduction, this is a very standard procedure where you reduce them somehow and you open up from delto pectoral, of course, and then you can reduce, you can remove your subscap with lesser tuberosity, take it away and reduce it and put the lesser tuberosity in the defect itself, which is a very standard procedure called modified McLaughlin procedure. But sometimes the defect is really too big and you don't want to be non-anatomical, like fixing the subscap in the groove. I would rather take off my subscap, take a bone graft and bridge it there, and then cover it with my normal subscap repair. So not always will you do modified McLaughlins. Sometimes if the defect is too big, you can do a bone graft, corticocanceller from iliac crest, and put it with 2 screws and repair your subscap in a normal way. It's more like a anatomical repair that way. Now, be prepared for additional posterior exposures. In cases which come very late, sometimes just deltopectoral may not give you an access. There's a lot of scarring here, and sometimes we actually may have to put a posterolateral incision akin to anterolateral and then manipulate from this side, and then use a periosteum elevator, gradually mobilize, and then only you can reduce it. So be prepared for additional posterior exposures if you're struggling too much with deltopectoral approach. Now, when it comes to reconstruction, at times, and I've seen 2 patients where there was a big posterior fragment. So after reducing this, if you do not reconstruct this posterior fragment to back where it was, you will have a recurrence. So at least in one occasion, I opened up from the back again and put 2 screws through this big posterior chunk which was there. And otherwise, in vast variety of only soft tissue injuries, if you mobilize them good enough for 6 weeks, all the posterior tissues get scarred. Sometimes they still may have a posterior subluxation, which you can later on correct, maybe by second surgery. But if there's a bony piece, I think it is mandatory to go in from behind and fix the glenoid lip back to place. If the defect is too big, and we come to things like hemiarthroplasty and arthrodesis or reverse shoulder replacement. Arthrodesis where the patient cannot afford, I think it's a one-shot solution. If the patient has too much pain, poor patient, you can fix it in a normal position and can have a reasonable results. Hemiarthroplasty again has gone out of fashion because you try to fix these implants in retroversion, which are abnormal retroversion, and they start eroding the glenoid somewhere or the other and become painful. So I think I've gone away from doing hemis here. Either I reconstruct them and I have a tendency to switch to reverse rather than doing a hemi, or reconstruct them with massive bone grafts, and somehow hemi has gone out of fashion in my practice. So some of the patients, he was I think almost 65-year-old, came almost 1.5 years later. That was the kind of massive defect, and this is about 10 years back, I would say. And I had no idea about reverse at that time, or and he was a kind of a villager, you can see. And I tried doing a bone graft. I took a iliac crest graft and reconstructed it and put the subscap normally. And you can see very, very comforting result after about a year of rehabilitation. Similarly, this young guy came to me after neglected dislocation, maybe 6 months, and that was the kind of movement he had. And we fixed it in a standard way, and he had a good movement, as you can see. So posterior dislocation is a very good operation to do. And I think my range of reconstruction has gone more and more with a lot of bone defect. Earlier, I would consider a hemiarthroplasty, but now I do bone augmentation. Anterior dislocation is more challenging to do surgery-wise, but fortunately, they do very well even without surgery. So if it's an elderly patient, I would say don't touch it. Posterior dislocation used to be missed, I would say, 70% times, but no more. I think it's being diagnosed with our awareness and also availability of CT. Close reduction can be tried carefully in both. And I've told you the duration in my practice, 1 week for anterior and about 4 weeks in posterior. Open reduction and management has improved over the years. We used to be very pessimistic about doing surgery in anterior dislocation, but I think now we have understood that there is a way to do it, and you can give reasonable results, particularly in younger patients. Replacement in those with more than 50% defect and elderly person, particularly reverse shoulder replacement, is a reasonably good option in elderly people. It gives a good result. It's a constrained joint, so it takes away the forces which are there to dislocate it. But even then, the incidence of instability would be slightly higher than a conventional reverse shoulder replacement. Thank you very much for your attention.
Thank you, Dr. Maheshwari, for your crisp message. The discussion will be at the end of the session.
Right.
I would request Dr. Sachin Avasthi for his greater tuberosity fractures. Welcome.
Good afternoon, everybody. The topic of my presentation is graded tuberosity fracture, whether it is forgiving or not. One would like to have a comment on why this topic is being taken up, because of the two major reasons. One is that it forms a very prominent part of the proximal humerus fractures, and it's almost like 20% of the proximal humerus fractures are isolated graded tuberosity fractures. And the second is a surgery without proper evaluation might lead to AVN, secondary osteoarthritis, and we all know how good the results of replacement are in shoulder joints. And the proper evaluation, pre-reduction, post-reduction, X-rays and CT scan, even with dislocation, can give good results. So actually, the graded tuberosity fracture is not always forgiving, because we hardly consider about the anatomical part of the fracture. Proximal humerus is basically composed of 4 major parts: the articular head, the greater tuberosity, the lesser tuberosity, and the shaft. The muscle insertions on these parts of the proximal humerus are such that they have a tendency to displace the fracture. The greater tuberosity fracture is actually an apophyseal type of fracture on which the muscular tendinous insertion is there of supraspinatus, infraspinatus, teres minor, and subscap is attached on the lesser tuberosity, which in combination leads to displacement of these fractures on the posterior and lateral side. Moreover, initially it was considered that the supraspinatus tendon, they have a major attachment on greater tuberosity superolateral aspect, but actually it is the infraspinatus tendon which gets attached on the superolateral aspect, and supraspinatus tendon has some insertions on the lesser tuberosity as well, crossing the bicipital groove. So this leads to the functions of rotator cuff, which is actually a hand pressing on the head. In classification part, the greater tuberosity has always been neglected, because even in Neil's classification, it was said that the displacement and the rotator cuff, as well as the displacement and vascularity of head articular fragment, are the major concerns. They gave it a separate entity out of the proximal humerus fractures. In AO also, the classification of proximal humerus was based on relationship between fracture fragments and humeral head articular segment. There it was classified as one part of the proximal humerus fractures, but nobody described the greater tuberosity fractures in totality. Till 2014, when Much gave a classification system which was much simpler. They said that it's only the three types. One is avulsion, one is a split fracture, and the third one is the depression kind of fracture, which is actually the therapeutic classification. The Neer and Neo classification had already received criticism for poor observer reliabilities. So Much classification is nowadays the most widely used classification system for greater tuberosity fractures as far as therapeutic is concerned. The mode of injury is important because most of the times the greater tuberosity fractures, they are doubted on X-rays, but if you know the mode of mechanism, the mode of injury, then you can expect that these fractures can be there. In old patients, they can result from the low velocity trauma, but they heal well. In young patients, they result from the high velocity trauma. As a result, the soft tissue component of injury is very high, and most of the times they are operated. Seizures and electric shocks are the indirect causes which lead to dislocation of the shoulder joint, leading to greater tuberosity fractures as well in association. In evaluation of the greater tuberosity fractures, one has to go for the clinical evaluation, which includes the history examination, the radiological evaluation, which is X-ray, CT scan, and 3D reconstructions, and neurovascular status if it is important, if needed. The clinical examination, since it is a patient of trauma, patient comes with the pain and difficulty in using the upper limb. The radiological assessment, where axillary view and anterior-posterior view in internal and external rotation is taken in order to accurately assess the fracture position, comminution, and associated fractures of sagittal neck and glenoid fossa. One ratio method was described initially to know about the displacement of the greater tuberosity fractures, which has actually a very high observer biasing. The ratio method was outdated. The ratio method was outdated once the advent of 3D CT scan came into picture, which can classify the fragments, the fracture into three types. One is minor fragment displacement, which is less than 5 mm, the moderate, which is 6 to 10 mm, and major displacement, which is more than 10 mm. Now, this classification was directly linked to the surgeons because this is how the surgical planning is being decided nowadays. Discharge. Laptop discharge. Am I audible? So, MRI scan is basically done in greater tuberosity fractures. If you are doubting a fracture, patient is having painful restriction of movement, but the fracture site is not very much clear in your X-rays. The MRI scan will tell you the site of fracture and the edema around the fracture, which can lead to your planning of the future course of management of the fracture. The vascular assessments are done only if needed. They are basically the MR angiography and perfusion scans. They can give you some idea about the vascularity of the fragment. Coming on to the management. In greater tuberosity fractures, on your right-hand side is the non-consenting people, because most of the times you can get people who are not ready for the surgeries or evaluation. They think they are good, so you have to leave them. There is no other option. But on the left-hand side, there is an active patient, and if surgery is needed or not, he is asking to you, then you have to obviously comment on the GT displacement. Nowadays, we are doing it by the CT scan method, but ratio method was also being used earlier when the 3D CT scan was not available. If there is non-displaced fracture on radiography, the non-surgical treatment is warranted. If there is a grossly displaced fracture of greater tuberosity, surgical management is warranted. There is an in-between moderate zone where 6 to 10 mm of displacement is there. There comes the role of the CT scan. If the displacement is more than 5 mm, you might advise surgery. In athletes and in overhead working people, the displacement amount is actually the 3 mm. So there are three categories. One is minor displacement, moderate displacement and major displacement. Minus goes for conservative, but minor has two divisions, 5 mm for normal workers, sedentary workers, and 3 mm for athletes and overhead workers. Conservative management is the shoulder immobilizer application, which is applied for 2 to 3 weeks. And after that, once the pain permits, the oscillating movement of arm, the active movements of arm are started after 4 weeks. If we see the literature, starting from Nies to Platzer to Zellad, all of them have doubted the results of conservative management in the form of some painful shoulder movement. Though their number was very high because at that time it was the conservative management which was majorly done. But they all were doubting their results in the form of painful range of movement. Then come the role of surgical management, which is done for moderate and major displacements. You can go for open reduction and internal fixation, and nowadays arthroscopic surgeries are also being warranted. But before we go for the surgical management, we have to once again look for the deforming forces which are actually displacing the fracture fragment. The rotator cuff muscles, they should be taken into the consideration. And in many series, the superior and posterior GT displacements have been described because of the attachment on the greater tuberosity of supraspinatus and infraspinatus tendons. Out of the surgical position, once you go for the surgery, some say that there is some depression of the fracture fragments because of the associated dislocations of the proximal humerus. Now, if you're going for open reduction, if you reduce your greater tuberosity fracture in that depressed portion of the proximal humerus, then your reduction is not good. So the consensus was made that the anterior fracture line is the more reliable reduction guide for anterior-posterior fragment positioning of the greater tuberosity fragment. So these are the two basic principles which need to be taken care of. In avulsion type of fractures, they are treated just like as rotator cuff tears. Orthoscopic or mini open surgical techniques are used. You can fix it by tension band screw or even simple screws. This is a X-ray of the patient which has been fixed by tension band wiring over the cannulated cancellous screws. If you are going for arthroscopic mini open surgeries, you can reduce the fracture fragment and go for the fixation with the suture bridge techniques. In a split type of fractures, there are basically 3 main types through which you can fix it. One is interfragmentary compression screw. Second is a small locking plate augmented with sutures through the rotator cuff tendons. And third is double row suture bridge technique. So this is a case of cannulated screw fixations. I think most of us are doing it. This is a case of a small locking plate which has been augmented with the sutures for the rotator cuff. The sutures are actually tied on the plate just to hold the fracture position as you are holding the apophyseal fractures, and then a plate is applied over the fragment just to buttress the positioning. This is a suture bridge technique where one anchor is put on the head side, the cancellous bone. The threads are passed through the rotator cuff where they attach on the greater tuberosity and tied over the rotator cuff. Then this whole portion is pulled and anchored on the shaft of the humerus, preferably taking a 1 mm bridge gap. In depression type of fractures, usually you don't require any treatment because they are in their place. But if they get displaced, then you might have to use a surgical approach, which is actually used for avulsion type of fractures. The outcomes are good for undisplaced fractures by conservative management. And if fractures are displaced, the surgical results are also good. Only literature says that bony fixations have always good results in majorly most of the series. Platzer told that screw fixation is better for tension band wiring as compared to K-wire fixation. In plating, the results were 95% good to excellent. This is the bony fixation technique. For orthoscopic repairs, Lin and colleagues, Zhi and colleagues, and Psychorius and colleagues, they all have told that the suture bridge fixation is a much better fixation method because it takes care of rotator cuff as well as the bony fragments both. So the conclusion is
that the greater tuberosity fractures, they give good results. Proper evaluation is the key. Non-surgically treated patients need careful watch for any displacement of the fragments during the course of the treatment. Surgically treatment patients need proper rehabilitation for the excellent outcome. Thank you.
Thank you, Dr. Sachin. Now our next speaker is Dr. Sandeep Garg. Minimal invasive fixation, proximal humerus fractures. Before ending the session, there will be one more lecture which has been left. Dr. Rajiv Raman from Kolkata. So please be ready, Dr. Rajiv Raman.
Respected members on the chair, dear colleagues, first of all, let me begin by thanking the organizers, especially Dr. Ashish and Dr. Uttam and rest of the organizers for giving me this opportunity. I think in 2 years of this pandemic, we all have studied a lot through webinars. Some people even called it death by webinar. What we missed was this get together. And today, Dr. Ashish has organized this get together, which we have been missing for almost 2 years now. So thank you, Dr. Ashish. So my topic for discussion today is minimally invasive proximal humeral fractures. As we know, proximal humeral fractures defined as fracture occurring at or proximal to surgical neck, 80% of all humeral fractures, 7% of all fractures, usually in patient more than 65 years, and second most common fracture of the upper extremity. So usually it can be 1 part, 2 part, 3 part, 4 part, but usually the comprises of 4 major segments: the articular head, the greater tuberosity, the lesser tuberosity, and the shaft. So there are certain anatomical details which are more important as far as arthroplasty is concerned. But what is important as far as fracture fixation is concerned is the anatomy of the blood vessels. Especially if the medial calcar of the humerus is spared, then the circumflex artery is spared, otherwise it is damaged. And the importance of axillary nerve lies in minimal invasive surgery, because here we are not going by the deltopectoral approach, we are going by the deltoid splitting approach. So we need to know where exactly the axillary nerve lies. And the deforming forces of the proximal humeral fractures are important because we need to restore these forces. The greater tuberosity is pulled posterior-medially by the effect of the supra and the infraspinatus tendons. The lesser tuberosity is pulled anteriorly by the subscapularis tendon, and the shaft is pulled anteromedially by the pectoralis major tendon. There are different classifications which are all academic: Codman's classification, Neer's classification, and of course the AO classification. So management is clearly defined into the non-operative and the operative treatment. And operative treatment could be closed reduction with percutaneous pin fixation or JES, intramedullary nailing, which is not very popular in our part of the world, open reduction with an LCP, and shoulder arthroplasty. So if we look into a management algorithm, then minimally displaced or undisplaced fractures, or they are displaced 3 or 4 part fractures. So minimally displaced fractures can be managed either conservatively or close reduction in pinning or JES, depending on what you're comfortable with. And displaced 3 or 4 part fractures can be managed by the classical deltopectoral approach using the plate osteosynthesis, or by the deltoid splitting approach using the MIPO technique. Treatment of displaced humeral fractures is complex and requires careful assessment. Patient factors, age, and activity level needs to be looked into. Fracture-related factors are bone quality, fracture pattern, degree of comminution, and vascular status. And the goal of treatment is a pain-free shoulder with restoration of pre-injury function. So minimally invasive would be defined as access to bone through soft tissue windows, minimal trauma to the soft tissue and to the bone by indirect reduction, minimal additional trauma at the fracture site, and tools which cause small fingerprints, which are basically sutures applied to different tuberosities. Now, I'll discuss only the minimally invasive MIPO technique. The patient is positioned prone and is positioned supine position with a bump or a roll under the spine or the ipsilateral scapula. Elevation of the head of the table reduces venous pressure of venous congestion in the area in the operative field. Alternatively, if you are comfortable, then a beach chair position can be adopted, but then you need to be comfortable with that position, and you need to be comfortable using the image intensifier in that position. And before you start your procedure, the C-arm needs to be positioned. It can be either come from above the head or across the table from the opposite side. The incision is 5 centimeters made from the tip of the acromion distally in line with the arm. It is generally made at the posterior edge of the clavicle, but can be adjusted according to pathology. Superficial dissection, the deltoid is split in line with the fibers no more than 5 centimeters distal to the lateral edge of the acromion. A stay suture is placed at the inferior edge of the split to prevent propagation of the split, because inferiorly lies the axillary nerve. Deep dissection is subacromial bursa lying deep to the deltoid muscle and can be excised to reveal the underlying rotator cuff insertion and the proximal humerus. This can be extended by only a second window and separate deltoid split distal to the axillary nerve. And that is of course required when you're doing a plate osteosynthesis. So the danger is of course damage to the axillary nerve. It leaves we need to understand and identify its position, leaves the posterior aspect of the axilla by traversing the quadrilateral space, the teres minor, major, along with the long head of biceps and medial border of the humerus. It travels along the humerus, coursing anteriorly and laterally to enter and innervate the deltoid via its deep surface. At this point, it runs transversely 5 to 7 centimeters distal to the edge of the acromion from posterior to anterior. So we cannot extend the split further due to risk to denervation of the anterior deltoid. Need to make a second incision distally in order to provide a safe second window for plate fixation. So here's an example. This is a 2-part fracture. Position lying on the acromion marked and the incision marked. 5 centimeter distal, up to 5 centimeters distal to the acromion. The self-retaining retractor applied, exposing the bursa, and then after reduction of the fracture, the plate is inserted using the sleeve as a handle and checked under fluoroscopy for positioning. And then you put a guide wire proximally and then make the distal window, put a sleeve distally and put a guide wire distally. So once you have both these sleeves there and both the guide wires in the correct position, you can proceed with putting the screws. And this is after the surgery and the final result. So the benefits are definitely the blood loss is less, and the patient is far more comfortable post-operatively. Now, in case you have a 4-part fracture, then you need to use sutures to bring the greater tuberosity fragment and the lesser tuberosity fragment together, and can be done very easily. Another example, and another example in which the same procedure can be extended to long fractures using a long phelos. So the take-home message would be, MIPO is a safe and effective option for treatment of proximal humeral fractures with good functional recovery and fewer complications, which are typically technique dependent. Reduction may be difficult, resulting in varus progression. Another disadvantage is risk of axillary nerve injury. Careful surgical technique and correct implant selection is important in the prevention of nerve injury. Furthermore, our results indicate that this method, compared with open reduction internal fixation, may be associated with lower rates of wound infection and a shorter stay of the patient in the hospital. Thank you.
Thank you, Dr. Sandeep. Before discussion, we would like to invite Dr. Rajiv Raman. Dr. Rajiv Raman, please. What is the current role of remplissage as an adjunct procedure? Bipolar fixation, Dr. Rajiv.
Thanks to UPA for invitation and warm greetings from Kolkata. Respected Chairperson, Professor G.K. Singh sir, A.K. Srivastava, A.K. Sirohi sir. So I will be talking on what is the current role of Rempeslaz as an urgent procedure for bipolar fixation. So before my talk, some of my residents are here, as a senior residents are also here. So I would request all of you to go with this article of Itoi. This is a very important article and very interesting article on off and off track lesion. What are the off track lesion and what are the on track lesion? And one must know in which type of on track or off track or engaging or non-engaging Hill-Sachs lesion, what are the treatment options you will plan? So normally you have a glenoid bone loss. It may be because of a fracture or because of erosion. Sometimes you have a fracture of the glenoid, and sometimes what happens, you can see here, there is a loss of the anterior and inferior part of the glenoid because of the fracture. And sometimes you have erosion of the anterior and inferior part of the glenoid because of recurrent shoulder dislocation. The recurrence is one of the important cause of erosion of the anterior and inferior part of the glenoid. And definitely, the burn is not only on the glenoid side, the burn is over the humeral head side also. So you have a bone defect in the humeral head side, which we call it a Hill-Sachs lesion, and that can be quantified or measured by the CT scan or MRI. So what is bipolar lesion? So we should not be confused with the psychiatric term of bipolar lesion. Bipolar lesion, normally if you see the shoulder dislocation rates, so 4 out of 5, almost 80% of the shoulder will have both the Hill-Sachs, that the humeral head defect, and the glenoid bone lesion, which is called a bipolar lesion. So what is bipolar lesion? If you have a defect in the glenoid and a defect in the humeral head, yes, those lesions are bipolar lesion. And these are challenging lesions, and normally we should think about how to manage them in proper way. One important term comes when we describe the anterior inferior instability, the glenoid tract. Or what is glenoid tract? Normally, it's a contact zone of the glenoid with the humeral head, and we call it a glenoid tract. And if you see what is on track and off track, and this is very important when we plan for a recurrent dislocation or a anterior shoulder instability. So on track lesion is when we are abducting your shoulder and putting it in an external rotation, there is a gliding movement of the humeral head from posterior to anterior part. And this tracking is from the posterior to anterior part, not superior to inferior part. So normally this track is called glenoid tract. That is a contact of the area of the humeral head with the glenoid. So if there is any bone loss either in the glenoid or in the humeral head, what will happen? The ball will stuck with the socket, that is with the glenoid, and we call it as a engaging lesion, that is a engaging Hill-Sachs. And a simple way is like that. Suppose your tire is your humeral head and your road is your glenoid. So if there is a big crater inside the road, what will happen during abduction external rotation, or humeral head, that the tire of your car will get engaged in the tract, and that is called engaging Hill-Sachs. So you should identify whether your lesion is an on-track lesion or an off-track lesion. So what is Rempeslaz? Rempeslaz is a French word which means to feel. You want to feel the cavity. There is a cavity in the posterior and superior part of the humeral head. You want to feel it, and this procedure was described by Wolf in 2007, and that was published in Journal of Arthroscopy also. And now it's a very common procedure we do for bipolar shoulder lesion in recurrent dislocation of the shoulders. What we do in Rempeslaz, normally you see the defect in the posterior part of the humeral head, posterior superior part of the humeral head. So what we do, we tie the infraspinatus with the capsule in the posterior part of the humeral head, so that the intra-articular defect is converted into extra-articular defect. And once you cover this, the excessive anterior mobilization of the shoulder, a gliding of the shoulder is restricted. And most of the time, if you have a glenoid bone loss with a humeral head bone loss, the shoulder will not dislocate because you have reinforced it posteriorly also, and you have a bipolar fixation. So this is a small video. You can see the huge amount of bony defect is there in the posterior and inferior part. And here you can see this is engaging Hill-Sachs. So while putting it in abduction external rotation, the defect is getting engaged with the anterior glenoid rim, and that is important. And this is one of the important indications for Rempeslaz procedure. The first step is clearance of the fibrous tissue. Try to remove all the fibrous tissue from the posterior part of the crater, so that you have a good healing of the soft tissue over the glenoid defect. Try to put your anchor over the center of the defect. Normally you have a crater there, so try to put the anchor over the center of the defect, and always use a double loaded anchor, because we want a good parachute type of fixation of the whole of the infraspinatus over the crater. Now you see, you try to park your all the four suture through the anterosuperior portal. And once you park your suture in the anterosuperior portal, start taking your bite from the infraspinatus and the capsule. And this is very important step. Once you start taking bite from the infraspinatus, before that, you have to remove your cannula bag, straight your bird beak or a straight penetrating grasper, and you can see by this penetrating grasper, try to catch your sutures. There are two double loaded ankles, both are of different color. You have a tiger suture and you have a purple suture. So try to take first bite from the tiger suture, then try to take your next bite with the purple suture. And now what will happen when you will tie this? It's like a incorporation of the infraspinatus in the crater. And this we call it a parachute technique. You can see here the whole of the infraspinatus is getting incorporated in the crater, and gradually as you tie knot, either a sliding knot or a half inch knot, the whole of the infraspinatus will get sit over the crater, and by this you are converting a intra-articular defect into extra-articular defect. So this is a very important procedure we use routinely for the bipolar type of lesion where you have a glenoid bone loss and a humeral head bone loss. And now you can see, once you have tied it, your head is centralized. This is the important part, because what happens in recurrent dislocation of the shoulder, most of the time the head lies in the anterior and inferior quadrant. So you want to centralize the head. You have done your soft tissue Bankart repair anteriorly, you can see, and you have reinforced it with a rempiscillage posteriorly. The whole of your head is centralized over the glenoid. So you have a concentric glenohumeral motion when the patient will go for an abduction and external rotation. So what should be your treatment plan? So normally, you have a glenoid bone loss. If it is less than 20%, whether you are dealing with an engaging Hill-Sachs or a non-engaging Hill-Sachs, always try to go with a rempiscillage procedure. If the glenoid bone loss is more than 20%, that means almost more than 20% of the anterior inferior part of the glenoid has been lost. In those cases, try to go for a Latarjet, because if you go for a isolated rempiscillage or Bankart repair, chances of failure are quite high. If you have a Hill-Sachs lesion with more than 20% involvement of the humeral head with or without glenoid bone defect, yes, you can plan for rempiscillage. So I think rempiscillage is a very good procedure for recurrent dislocation of the shoulder when you are dealing with a bipolar type of lesion in the humeral head and lesion in the glenoid. Thank you so much.
Thank you, Dr. Rajiv. The whole session is open for the discussion. I will request the speakers who are here to please come on the dais. Dr. Sachin Avasthi. Any questions? If there are no questions, we will be preparing for the next inaugural function. And before that, I would like to thank the organizers for giving us the opportunity to chair the session. And I would like to thank all of you, sir, for the continuous support which I have got from UPOA, from all the members and office bearers, from president, from secretary, and all the club secretaries and all the members. As you know, I am contesting for the vice president of IOA this year. I thank you all for the support from my heart and hope that you will be giving me a big victory. Thank you, sir.
लास्ट जब मैं ही तो वोट ऑफ थैंक्स पे हूँ लास्ट. So as we are preparing for the inaugural function to take place, our chief guest, our honorable Vice Chancellor, Professor Lieutenant General Bipin Puri sir is with us, and we have all our teachers, eminent past presidents and other people from here. I request all the delegates to kindly take their seats. It will take just 2 minutes that we are starting with the inaugural function. So please be seated in the hall. Dr. Amit, please take your people along with you and be seated. ये क्या यार क्या कर रहा है?
हाँ सर सब सर हाँ वो नहीं देना वो मैंने पता किया
Hello. Good afternoon, everyone. May I request everyone to please take your seats because we are going to proceed for inauguration ceremony of this MTS. So good afternoon, everyone. I welcome you all in the inaugural ceremony of MTS of UPOA. Now I shall invite the dignitaries to come on the dais, and I will request Dr. Abhishek Saini and Dr. Uttam Garg sir to please welcome our guest with flowers. Now I invite President UPOA, Dr. Sanjay Dhawan, to please come on the dais and take your seat. I will request Dr. Abhishek Saini to please welcome Dr. Sanjay Dhawan with bamboo pot. Now I will invite our chief guest of today's function, Lieutenant General Dr. Vipin Puri, to please come on the dais and take your seat. I will request Dr. Uttam Garg sir to please welcome our chief guest with bamboo pot. Sir, thank you, sir. Now I will invite guest of honor of today's function, Dr. Atul Srivastava sir, who is Vice President of IOA, to please come on the dais and take your seat. I will request Dr. Uttam Garg sir to please welcome our guest of honor. May I request Secretary UPOA, Dr. Anup Agrawal, to please come on the dais and take your seat. Sir, welcome, sir. I will request Dr. Abhishek Saini to please welcome Secretary UPOA, Dr. Anup Agrawal. May I request Chairman Organizing Committee, Professor Vineet Sharma sir, to please come on the dais and take your seat. And we'll request Dr. Uttam Garg sir to please welcome sir. May I request President Lucknow Orthopedic Society, Dr. Harish Makkad, and Secretary Lucknow Orthopedic Society, Dr. Santosh Singh sir, to please come on the dais and take your seats. I will request Dr. Abhishek Saini to please welcome our guests. Welcome, sir. Now I will invite President-elect UPOA, Professor Ashish Kumar, who is also organizing secretary of this symposium, to please come on the dais and take your seat. And I will request Dr. Uttam Garg sir to please welcome Professor Ashish Kumar. Thank you very much, Dr. Uttam Garg sir and Dr. Abhishek Saini. As we always start our academic activities with lighting of the lamp and prayer of Goddess Saraswati with Saraswati Vandana, I invite the dignitaries on the dais to please come forward and light the lamp. Thank you very much, sir. Now I shall invite Chairman, Organizing Committee, Professor Vineet Sharma, sir, for welcome address.
Thank you, Sanjeev. Honorable Vice Chancellor, the chief guest of this function, Lieutenant General Vipin Puri, our President of UPOA, Dr. Sanjay Dhawan, Vice President of IOA, Dr. Atul Srivastav, Dr. Anup Agarwal, Secretary UPOA, Secretary Lucknow Orthopedic Society, Dr. Harish Makkar, and President Lucknow Orthopedic Society, Harish Makkar, Secretary Orthopedic Society, Dr. Santosh, Organizing Secretary, Dr. Ashish. My teachers, seniors, my fellow colleagues, delegates, it's a pleasure to welcome you all to the inaugural function of midterm UPOA. I think it's after 2 years that we are holding this function as a physical presence. Though it's a hybrid presence, in the forenoon we have already had 3 continuous sessions in which faculty from different parts gave knowledge, and their knowledge was imparted to you all. Shoulder is basically one of the most complicated joints of the body, requiring a lot of technical intricacies for the management. I'm sure this topic chosen by the organizing committee is apt for this function, and I'm sure you will all go out with new ideas for the management and the diagnosis of shoulder problems. The organizing committee has taken pains to organize this in the best manner they could. Of course, there are certain lapses, certain problems that can be there, and we are all there to say sorry for any lapses that we have. I'm sure you'll enjoy the day. It will be a good academic as well as cultural feast. I welcome you all again to the city of Lucknow. Thank you.
Thank you very much, sir. Now I shall invite Secretary UPOA, Dr. Anup Agarwal, to come on the podium and present Secretary's report.
Honorable President UPOA Dr. Sanjay Dhawan, Chief Guest of the Day, respected Dr. Vipin Puri, Vice Chancellor KGMU, Guest of Honor, Vice President IOA Dr. Atul Srivastav, President-elect UPOA Dr. Ashish Kumar, President Lucknow Orthopedic Society Dr. Harish Makkar, Secretary LOS Dr. Santosh Singh, Organizing Chairman Dr. Vineet Sharma, my seniors, dear friends, people from press, media and pharma companies. At the outset, I would like to congratulate Dr. Ashish Kumar, Dr. Uttam Garg, Dr. Sanjeev and his team for their magnanimous efforts in organizing MTS, especially after such a bad COVID episode. I'm sure you all must be having good academic with best Lucknow hospitality as ever. We could not organize anything physically from March 20 to the first half of 21. And since then, we had organized UPOA special course by the team Gorakhpur led by Dr. Pawan Pradhan and Dr. Amit Mishra. And thereafter, UP Orthoplasty course led by Dr. Kapil Kulshrestha and Dr. Anurag. These both courses were online. So this is the first course which we are organizing physically during the COVID time, after the COVID. We also had our unique academic program called Friday Musing that was absolutely online every Friday on trauma by Dr. Unmesh Chakravarti from Varanasi, arthroscopy by Dr. Ashutosh from Varanasi, hand and wrist by Dr. Ajit from Kanpur, and pediatric trauma by Dr. Ajay Singh and Dr. Najmul Huda, KGMU Lucknow. I'm thankful to them for their cooperation and organizing these wonderful Friday webinars. On coming October, that is 17th, we also have UPOA trauma course in Kanpur that will be organized by Team Kanpur. by the organizing secretary, Dr. TPS Lamba. And then on 27th and 28th, November, we'll have PGICL in Moradabad. And thereafter, our most awaited annual conference, UP OrthoCon, in February at Varanasi. I'm hoping that it is going to be a physical conference again like this one. Our team Varanasi is working hard to make it success, though I know it is really difficult because of the COVID to get into physically and organizing such conferences. It is our constant endeavor and commitment to keep you updated with the latest in orthopedics through these CMEs, which are equally useful for both postgraduates and private practitioners. And let me tell you, UPA is not only an academic body, but also has social agenda. Because by doing such CME and enhancing the skill of orthopedic surgeons, the ultimate beneficiary is patient. It's not just we orthopedic surgeons who get benefited out of it. So that is what we are serving to the society by enhancing the skill of orthopedic surgeons. And to continue with this of social agenda, UPA started the UPOA KGMU Clubfoot program, where UPO and KGMU together would work to update the skills of our members and spread awareness of clubfoot in the society. And I'm thankful to the Vice Chancellor KGMU for allowing us to do this with the help of Department of Pediatric Orthopedics under the leadership of Dr. Vineet Sharma and Dr. Ajay Singh and his team. KGMU soon will be organizing first such skill enhancement workshop in the coming month. Last year, we had 15 fellowships, but we could complete only 6 fellowships. So this year, our target would be to complete all these fellowships. Our journal is Index Copernicus and Google Scholar. My team of editorial board under the leadership of Dr. Najmul Huda are doing a splendid job, and it is now being published by Walter Kluwer. Today we had UPOA annual PG quiz. I must congratulate Dr. Latif Jilani for organizing this quiz. We had 6 teams, and I'm happy to announce that JNMC Aligarh won the quiz and KGMU Lucknow was the runner-up. There's another important news that today we have many members of Firozabad Orthopedic Club. I'm happy to share with you that we are now going to induct a new club, that is Firozabad Orthopedic Club. I welcome Secretary Dr. Vipul Agrawal of Firozabad Orthopedic Club for doing this wonderful job. Like every year again, this year we celebrated the Bone and Joint Week and Bone and Joint Day from 1st August to 7th August. And this year theme was Save One, Save Self. And CSRC committee of IUA decided to create 1 lakh life savers by training them with basic life-saving skills. And I'm glad to inform you that UPO alone could train more than 25,000 person and student. And across India, we trained more than 12 lakh instead of 1 lakh persons. And I'm grateful to all of you for helping me in achieving this milestone. Once again, I request you to please encourage your colleague to become member of UPOA and IUA. And I call upon all my colleagues to come forward and make UPOA the best chapter of IUA. Last but not the least, I'm thankful to all the members of UPOA for giving me this opportunity to serve the largest chapter of UPOA. Thank you everyone for being part of UPOA. Long live IUA, long live UPOA. Jai Hind. Thank you.
Thank you, Anup sir. Now I shall invite Dr. Sanjay Dhawan, President UPOA, for his presidential address. Sir.
Very good afternoon, dignitaries on the dais, off the dais, respected seniors and dear friends. I welcome you all to this midterm symposium of UPOA being organized by Lucknow Orthopedic Society. In this symposium, we have a much sought after topic addressing shoulder affection that starts from trauma running through arthroscopy and ends with arthroplasty was the need of the day. It was a long time coming and I am overwhelmed to be a part of this. UPOA has always been striving to nourish its member by imparting knowledge at latest development involving around the globe. And this is another such offering, which will include a case-based interactive session along with essentials of shoulder arthroscopy and arthroplasty, etc. The top faculty of our country shall be here to discuss various anomalies of shoulder and recent advances in the subject. I welcome them and thank them for sharing their wisdom. This very symposium, which is first of its kind, which we call it hybrid since it is being organized physically and virtually as well. Since this is on virtual platform too, I request all the attendees to kindly follow the protocol to make the course more and more interactive and result-oriented. My greetings are always there for the success of Symposium. My special mention goes to President LOS, Dr. Harish Makkar, Secretary LOS, Dr. Santosh Singh, Organizing Chairman, Dr. Vineet Sharma, sir, and Organizing Secretary, and who is also the President-elect of UPOA, Dr. Ashish Kumar, with his two dynamic duo Joint Organizing Secretary, Dr. Uttam Garg and Dr. Sanjeev Kumar, and the team. And their continued personalized efforts shall make this MTS a memorable one. We have seen the enthusiasm of UPOA for a whole week from 1st of August to 7th of August 2021 during the Bone and Joint Day celebration. The efforts of CSRC team headed by our own Dr. Anup was commendable, for which they deserve a round of applause. Further, we all tried and made the virtual academics happen during this hard pandemic COVID time. For that, I congratulate over our UPA all members. I wish LOS and the organizing team a grand success for the midterm symposium. Thank you. Long live UPA. Jai Hind.
Thank you, sir. Now I will invite guest of honor of today's function, Dr. Atul Srivastava, who is Vice President IOA, to please come on the podium and address the meeting, sir.
Thank you, Sanjeev. Good afternoon, all. Respected seniors and dear friends, it is indeed a great pleasure to be meeting you all after a very long time, in person, face to face. I must congratulate our past secretary and president-elect and the organizing secretary of today's function, Dr. Ashish Kumar Srivastava, for organizing such a wonderful event, of course, under the able guidance of Professor Vineet Sharma and with the support of our joint organizing secretaries, Dr. Uttam Garg and Dr. Sanjeev Kumar. And of course, all the members of Lucknow Orthopedic Society with its president, Dr. Harish Makkar, and secretary, Dr. Santosh Kumar Singh. Congratulations once again. We should also appreciate the efforts of the UPOA president, Dr. Sanjay Dhawan, and our dynamic and competent secretary, Dr. Anup Agarwal, for continuing the academic activities of the UPOA wonderfully well in these trying and testing times. As Dr. Anup said, and we all know, he also happens to be the chairman, and it's a very prestigious post, the chairman of the CSRC Committee of the Indian Orthopedic Association. And I can say this, that this year, despite all handicaps, the Bone and Joint Week celebrations were the best ever held in the last 10 years since its inception in 2012. I would like to congratulate Dr. Anup and his team for the same. Once again, it is a pleasure being with you all in person. Thank you very much. All the best. Try to still stay safe. Jai Hind. Thank you.
Thank you, Atul sir. Now I will invite chief guest of this inaugural function, Lieutenant General Bipin Puri sir, the Honorable Vice Chancellor of King George Medical University, Lucknow, who is a very humble and nice human being and also a very able administrator, to please come to the podium and deliver the inaugural address. Thank you, sir.
Good afternoon, friends. I don't see any ladies, it's only gentlemen. So good afternoon, gentlemen. Professor Vineet Sharma, the organizing chairman of today's function, Professor Ashish Kumar, the organizing secretary of this hybrid conference, Professor Atul Srivastav, President, UPOA, and now the Vice President of Indian Orthopedic Society, Professor Sanjay Dhawan, President of the UPA, Dr. Anup Agarwal, Secretary, UPOA, distinguished dignitaries of UP Orthopedic Association, eminent faculty from UP and outside, delegates and friends, colleagues. At the outset, let me begin by saying that I am the only pediatric surgeon today in this gathering, and I could not feel more secured, at least from bone health point of view, how secured I am, surrounded by a sea of orthopedic surgeons. So it's a pleasure, friends, gentlemen, to be with you all this afternoon. More so because it's a very important academic event, a symposia of the Lucknow Orthopedic Society. Well, I sincerely believe that academics topping up of knowledge and keeping abreast with contemporary information is absolutely mandatory. And in that context, my compliments to the Lucknow Orthopedic Society and the Department of Orthopedics at the King George Medical University for organizing this midterm symposium 2021 in a hybrid platform. I see this and I underscore this point because, friends, you'll all agree with me that COVID in the year, a year and a half or 2 years that have gone by, amongst many other things that it has taught us the online platform. It has taught us to use the online platform more effectively. And I'm sure in times to come, in the coming years, we are going to use this platform effectively and try and connect with the who's who in your vertical, in your domains, in your subsets across the world. And I think this would be more useful, more effective, and more meaningful connect with our own iconic doyens in our field across the world. So coming to our symposium today, I think I'm told that it's addressing shoulder affections, including rotator cuff lesions, issues of mobility and stability of the glenohumeral joint, which continues to be a challenge even today, despite huge number of innovations. In this context, I think it is a very important topic and it definitely requires much more deliberation and analysis. But let me say this, that minimally invasive surgery on the shoulder has changed our understanding in all fields, but let's talk today only of the shoulder as far as the diagnosis of shoulder injuries by better arthroscopic procedures, including diagnosing lesions like the Bankart's and the Hill-Sachs lesions, and nuanced surgical procedures have brought in newer paradigms, evolution of newer advances in management protocols. Decision-making in rotator cuff lesions, implementation of newer technologies as bioengineered scaffolds, novel stem cell sources, and controlled release growth factors will navigate the future treatment modalities for shoulder pathologies in the years to come. I'm sure much of this will be seen by the new generation of orthopedic surgeons. I sincerely believe that joint preservation strategies require to be reaffirmed and consolidated, for which controlled pragmatism is a considered necessity. While total shoulder arthroplasty remains the last resort for treating severe glenohumeral disorders such as osteoarthritis, alternative therapies for improving healing of native tissues like tendon research have focused on preventing failures of rotator cuff repairs and augmenting the biological healing of the rotator cuff. I'm glad, friends, that today the scientific intent of this conference, under the chairmanship of Professor Vineet Sharma and Dr. Ashish as the organizing secretary, I've gone through that list, is absolutely exceptional. And I'm sure it's going to be an academic feast for all of you. Lucknow Orthopedic Society and the UPA have been pioneers in the provision of cutting-edge technology in this capital city of Uttar Pradesh. And I compliment all functionaries, past and present, as you carry the baton of knowledge to the new generation. I'm sure the dedicated support of Lucknow Orthopedic Society and the backing of the entire UPA committees and members will ensure that this will be an extremely memorable get-together for advancing our knowledge, upskilling, exchange of ideas, networking, good fellowship, and hospitality. Friends, gentlemen, it's a pleasure for me to be with you all today. I thank you all for your attention. Thank you and Jai Hind.
Thank you very much, sir, for your kind words and blessings. Now I will invite our very energetic and dynamic organizing secretary, Professor Ashish Kumar, who is also Vice President of UPOA for this year, to please come to the podium and deliver vote of thanks.
Thanks, Dr. Sanjeev. So this is a time for thanking all of you for being part of the symposium and contributing whatever means you could have done. I see many of my teachers, retired head department, many faculties, many senior orthopedic surgeons in this gathering, and I must say thanks to all of them. Now I will be reading out something that will be missing many names, so kindly forgive me and take with this beginning sentence, then I am thankful to all of you. So first and foremost, I am grateful to our chief guest, Honorable Vice Chancellor, KGMU, Lieutenant General Vipin Puri sir, for gracing the occasion and sparing time for his extremely busy schedule. He is busy on Sundays also, we all know it. Dr. Atul Srivastava, our IO Vice President right now and former President and Secretary of this association, UPOA, and a very good friend of mine, I feel honored to thank him for coming. Dr. Sanjay Dhawan, President UPOA, is the main person for all this event. I am thankful to him for being here and constantly guiding us. Dr. Anup Agarwal, Secretary UPOA, Dr. Harish Makkad, President LOS, Dr. Santosh Singh, along with Dr. Uttam Garg, Dr. Sanjeev Kumar, Dr. Sachin Awasthi, Dr. Abhishek Saini, all other doctor friends who worked hard with me under able guidance of Professor Vineet Sharma sir, our organizing chairman, to make this event successful. All our past presidents of our EC members, our seniors, our quiz master, Dr. Latif Chilani, all the delegates traveling from far off places to make this event successful. Our eminent faculties, Dr. Rajiv Raman, who is present physically here, and many others who presented online, like Dr. Sanjay Desai, Dr. Amravati, Dr. Sudhir Kapoor, Dr. Deepak Bhatia, Dr. Jiten Maheshwari, and all my state faculties whom I have troubled to come here and present their work on the shoulder problems. A big list is there, but my chairperson, other moderators who made this program keep going and a grand success. I'm grateful to all pharma people whose contribution and support was the backbone for this program. I thank my all media persons who are here, and I hope who spared time and will stay with us lunch for the lunch and will cover the program well. And at the end, lastly, my supporting staff, Anurag, Shivshankar, Rishi, Priyanka, and all others who have worked hard day and night, at least for a week, they are working hard. So I am very grateful to them. So at the end, whom I have forgotten, again, I thank all of you once again. Thank you very much. We will come to the end of this program. There will be EC meeting upstairs on the first floor, and I will ask rest of the people to go for the lunch after the national anthem.
Thank you, sir. Now I will request everyone present in this hall to please rise for national anthem.
जनगणमन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगल दायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Thank you very much. EC meeting of UPOA will take place in the hall at first floor immediately. So I request the EC members of UPOA to please reach first floor hall.
The next session will start at 2:30 sharp. Please be here. Thanks.